Champaign County Board study session on our nursing home. And I would ask for a roll call, please.
Carter. Here. Coert. Present. Esri. Here. Harper. Here. Hartke. Here. James. Here. Jay. Here. Kibler.
Here.
Langenheim.
He's
Maxwell.
Here.
McGuire.
Here.
Michaels. Mitchell.
Here.
Petrie. Here. Quisenberry.
Here.
Richards.
Here.
Rosales.
Here.
Schrader.
He's ill tonight.
Schwartz. Here. Alex.
Here.
Berkson. Kurtz.
Here. Okay. I'd like a motion to approve the agenda, please. So moved by James, second by Mr. Rosales. Any discussion? All in favor? Aye. Opposed? Motion carries. Approval of the agenda. All right, here's how we're going to work this evening. We'll have public participation next. I have a couple here. In public participation, we give you 5 minutes, and we have 1 hour, but obviously it was only 2 tonight. So there'll be a 5-minute limit for each public participation. And I'd like to call first, I'm not sure which one came in first, Mr. Paul Schneider, is it?
Yeah.
What's the matter? I'm sorry, our head's in the way?
Mr. Schneider doesn't have a place to go.
Mr. Schneider needs to sit somewhere at that table, please, Chris, for public participation. Thank you. Sir, please have a seat. And turn on your microphone. Just press the middle button. There you go. Go ahead.
Thanks. My name's Paul Schneider. I'm a registered Champaign County Republican, local small business owner. I'm here to express my concern over the apparent desire of some board members to sell the nursing home to private interests. My concern is based on the fact that the county nursing home sets the standard for aged care in this area. My father was a paid patient in the nursing home and received far better care than he did at the local private home. I also understand that private homes are required to admit only 10% of their total patients as Medicaid patients. The county home now has 60%, from what I understand, Medicaid patients. I'm concerned about what's going to happen to this extra 50%, and I wonder if that's come up in the discussions. I understand that the county home is meeting its financial obligations now. And in my business, I understand that if it's not fixed, or if it's not broken, don't fix it. So I'm wondering what the intent of this is. And I've been kind of puzzled by this until I looked at there's been a move to get a new jail at the same time. And I'm wondering if these two things are connected. And I'm thinking that if there's something wrong that's broken at the jail, maybe we ought to privatize the jail instead of the nursing home. Those are my thoughts on that. Now, when I told my mother, who's 94, about this, she was concerned, and she wanted to be here tonight. And she was feeling under the weather and asked me to read a statement. I trust I'm not going to go over I'm kind of hurrying here. I'm not going to go over the 5 minutes, but I'd like to read this. Here's what she says. I'm Francis Schneider, 94 years old, been a resident of Champaign County for 61 years. My husband served on the county board as a Democrat for 13 years. He was on the committee for the nursing home. He was also a resident in the nursing home from 2006 and died there in May of 2006. He received excellent care. In my long experience with my father and mother, both being served by nursing homes in Champaign County in their later years, I do have a basis for my reasoning. I feel it's important for the county to keep control of the home. Jack, who's her husband, my dad, received better care, better food, and a better environment in his situation than any he could have gotten at a private nursing home. There are many people in Champaign County who've been paying taxes and supporting the home for many years. They deserve to have a caring place to spend their declining years when they need round-the-clock care. They deserve to have a place that the care is not governed by the bottom line on the balance sheet. When the nursing home becomes privately owned, the costs begin to be cut and the price of care goes up. If it comes to spending money on a new jail, instead of keeping the nursing home under the county board supervision, I think there's no choice. The people who have supported the nursing home for years, and they need their care and needs should be considered first. Thanks.
Thank you, Mr. Schneider. Our next public is Belden Fields, sir.
Well, I want to second what Mr. Snyder said. My experience with the nursing home is that my mother lived in it the last 4 years of her life. We had experience with another private nursing home prior to her entry into that one, and there was absolutely no comparison in terms of the care which we received between the two homes. My sister-in-law's mother was also in that nursing home more recently, and I had a chance to visit it, and my impression was that the care was still really top level. I also worked very hard on the bond issue that we had for the nursing home back in, what year was that? 2002, right? And I found tremendous reception, both when I went to organizations to help fund it, particularly the AFL-CIO, because we needed signs. We had a big campaign for that, and also just walking the streets and knocking on doors. I found tremendous support for this nursing home. We have a county jail, which we're mandated to have. We don't have any choice with that, but I don't think that a jail is anything we can be particularly proud of. It may be a necessity, but it's not a nice necessity. I would say the same thing for courthouses. They're necessities, but not nice necessities. We are not mandated to have a nursing home, but we choose to have a nursing home. That's been part of our tradition. It goes way back to the county poorhouses. Not all counties do it, but I'm very proud that this county does do it. I also want to say that I was a little dubious when the management agreement was entered into with the firm from St. Louis. But from what I hear from people who are close, that is working out very well, and I'm glad that that was done, and that the nursing home right now is on good footing. I am concerned about the future of the nursing home, not because of anything that the nursing home is doing or that the people from St. Louis are doing, but because of what goes on in Springfield, and particularly the Medicaid issues. I had made a request to Pius Weibel when he was chair of the county board to see if some public safety money could not be set aside. It could be used either as a granting or a loaning fund for the nursing home. If it were a loaning fund, it could be replenished as the state tardily comes forward with the Medicaid funding. I unfortunately received no word back from Mr. Weibel. I don't know if that was looked into too. The rationale was this, that if the nursing home does sink, and let's say you have 50-50 or 60-50 Medicaid as opposed to private pay or Medicare, private pay, you're going to have a whole lot of either old or disabled people who are going to be dislodged with nowhere to go. Because if they can't afford it, the private nursing homes are not going to take them in. You cannot assume that they are going to have family who are going to be able to take them in, or that there will be sufficient home care in order for these people to be cared for. It would be an enormous cruelty, and it would be a public safety issue. So I strongly urge you to maybe think outside of the box in terms of what we can do should the contingency arise where the Medicaid payments fall so far behind that the nursing home needs a little extra, if you like, loan to tide them over the period. If that's not sufficient, we might think of granting, because again, I think this is a public safety issue. And I share the concern that Mr. Snyder had about spending a lot of money on a jail and losing the nursing home. To me, that's no exchange I want to see in this county. Thank you very much.
Thank you, sir. All right. Is there any other public participation? Anyone want to speak? All right, I'll close that now. Thank you. All right, then some ground rules. This is a study session. It's going to be sort of casual, hopefully. We're going to do a lot of discussing, questions. And so here's the order. Mr. Hartke will kick off our discussion. Then Mr. Gima from MPA will do a short presentation. Then Chris Alex on finance, and Mr. Quisenberry and Mr. Maxwell on structure and operations. So if you want to raise your hand during anyone's presentation, ask a question, or make a comment, please don't hesitate. We're here to discuss, and we want to get out everyone's opinions and make sure that each of you have your questions answered this evening. Okay? So, yeah, Mr. Rosales. Is this session being televised?
Being streamed.
It's being streamed right now. Yeah, and you look very nice, Mr. Rosales. Okay, you're right on there. Okay. Just want to make sure you're looking good. All right. We'll start with Mr. Hartke, please.
Thank you, Mr. Chairman, and good evening, everyone. I want to say first off that I'm very glad that we're having this study session. I would like to see for our board have more study sessions about some of the other counties' responsibility areas, especially those that, unlike the nursing home, are not virtually self-sustaining in their financials. The jail, where and how we build our roads, how we regulate our elections. I'd like to see all of those. I will definitely be calling for one on energy efficiency and on the carbon footprint, and yes, Mr. James, I use that term, carbon footprint of our county facilities. However, that will be down the road. Tonight, however, we're talking about the nursing home, and I would just like to kind of start with a story I've told a few people, and I shared with Tom Kasich about why I wanted to be a member of the Nursing Home Board of Directors. My father died in 2010 after spending 4 years in a nursing home in Effingham County. He had a severe disease called Pick's disease, and it was a slow thing, and it was very terrible and painful for our family. And it's important for me to be able to fight for this county nursing home to have the best care that it can. I was lucky. My father's the head nurse in his division was actually an old high school classmate of his, so we knew he was getting good care. A lot of families cannot always be guaranteed that. For one thing, they are more, some private nursing homes are more answerable to profit centers and boards of directors who have to make a profit rather than a community who's more interested in having good care. And not only did my father pass away in a nursing home, but so did my grandmother. So this is something I've been visiting nursing homes my entire life. And we were very lucky. My dad was a farmer who had very good retirement. So we were able to afford for him to have good care. There's a lot of people who cannot. And that's another important reason for us to have a public nursing home. Of course, my main level, this is probably going to blow some people's minds, and that my main concern is not going to be whether this nursing home constantly comes between 1 and 2 points of its annualized budget, but are we continually providing the best care to this community? Are we meeting our mission of being a home that Medicare recipients can come to? And I will talk more about that later. I know for one thing, after the several nursing homes I've been in my life, this is the finest smelling nursing home I've ever been in. And I think that that's a good point to say what kind of care level goes on at this nursing home. So like I say, I come to this from a different angle. And while I believe that the therapy and the dialysis are important investments, not just to increase the level of care, but they're also, so that we meet with this good high level of care I'm talking about, but also because they are huge potential sources of future revenue. Now, I know a lot of people do not support the American Health Care Act, but it is enacted law, and part of this is to encourage hospitals to send their patients out to nursing homes for recuperative care rather than maintaining them in the hospitals as a high rate. Medicare is going to start finding hospitals that then do readmissions constantly. So what we are trying to offer at this nursing home is an option for Carl and Provena and the local hospitals to know that if we send our outpatients to this nursing home, they will not be readmitted, therefore we are not going to pay that 1%. Therefore we up our Medicare numbers, and that's where the game is on our finances, is upping our Medicare numbers. Not only does it balance our budget, but it also allows us more room to fulfill the public mission of having more Medicare patients, or Medicaid patients here. Now, again, Medicaid, those Medicare dollars will extend our ability to add Medicaid patients, but of course the state, as we all know, is failing with that a little bit. Hopefully some of the Affordable Health Care Act will help with that, but also what we're really trying to work on now is we're lobbying with the governor's office and our local state legislators to make our county nursing homes in the state of Illinois first payees when it comes to Medicaid reimbursements from the state, since we are also public institutions, since we are taking people in that could not otherwise take care of themselves, the state should reimburse us first. So we are going to push on that really hard, and hopefully that's going to get us, to within the 6 months and help with some of these Medicaid issues. However, as we well know, and as some people have attested to tonight, and from what I can tell from, the reviews that are done, because as a public facility, we are required to keep reviews of how our care is handled, to keep real numbers on it. Private facilities are not. From what I can see, it's certainly the best care in this county, if not this region of Illinois. And it's a place where those of you, and obviously there are plenty of people here tonight who've had to make this choice like my family did, someplace that you can trust that if I leave my loved one there, they are going to get care. And that's important to me. Someplace you can trust that you know the care is going to happen, that they're watching out to make high care their mission, not making profit for a board of directors or for a group of investors. So, in my opinion, we must grant MPA. And again, I'm like some of the others here. Several years ago, I would have said that I think MPA is probably a bad idea and that we should hire an administrator that can run the business for itself. However, it seems to me that MPA has really turned things around. It is also giving us a nationalized look at how nursing homes are handled and bringing that home, something we would have to have a lot of skill set here to develop on our own. So I think it's a good move. And now if we can give this nursing home the space and time to continue to straighten out its financial course with proper oversight and assistance from this board, we can continue to make the numbers work and work better, because it become obvious to me from what I've seen and what I've heard from past residents that the care there works, and that is my main concern. So thank you for letting me address this group.
Thank you, Mr. Hartke. We have any questions or any other comments for Mr. Hartke? Mr. Carter, would you like to say something? Would you hit your button? Because I know we visited you in the nursing home. I want to talk about that. Go ahead. Hit microphone, please.
I can wait further on down the line, but.
Okay, that's fine. We'll have plenty of time to ask questions. If you'd like to make a comment now, go right ahead.
All right. Well, I had the opportunity to be in the nursing home as a board member, but as a patient twice. And I'm going to tell you, I really appreciated that, because I don't think I had any other facility to go to that I could get the treatment, and it wasn't perfect. But saying that, I used to be on the board that taking care of all the nursing home problem. But as people, we got to learn to put personal agendas aside, politics aside, and do what's right. When you take an oath, you swear to do what? To take care of the business of the county, not your personal interest. And that got in the way of our nursing home, and that was a sad deal. But we need the nursing home, and there's nothing wrong with the nursing home, but we let politics get in the way. It moved out the committee that was really gonna see that it was built right ran right. That never happened. And I've been dissatisfied with that ever since I've been on this board. And that's what happened. Politics got in the way, and we end up with a partly dysfunctional nursing home. It's the county nursing home. And we should be responsible for the operation of, and whatever direction that nursing home should go, we should be responsible for it. Not sit here and get the different departments and put in different little segments that we know not gonna work. And we had people come up and try to tell us that, but we didn't listen. We had to go down the other direction. And while I was in the nursing home, they were so gracious to have me to come to 2 meetings during the time I was in there. Came down and got me and wheeled me up there in the meeting. And I observed what was going on, and there was things that we could have did as a board to correct them. But we had another entity sitting there that's supposed to be the boss, and some reason we didn't want to interfere with that, which was wrong. It was perfectly wrong. And now I'm in favor of everything that this board not privatizing. That's the wrong way to go. We need that nursing home. And we need it for people that can't pay $3,000 a day to live in it. You have people that can't do that. And if it's privatized, you know what's gonna happen. A lot of poor people that need a place to go won't have that opportunity. And I'm just proud that I did, I was able to go there and experience what we need to do. And I'm intending to work with this board and getting that done, if possible. I know it's hard. It's hard to put aside the politics, but we're gonna have to work on doing that and do what's right for that nursing home and Champaign County. I'm gonna close. I'm gonna close, but I just had to tell you how I felt and what I enjoyed when I was in there. Thank you.
Thank you, Mr. Carter. Ralph, can we move to the next section, or would you like to make a statement now? Could turn on your microphone, please.
The statement I have to make is very short and pertains to
Go right ahead.
the topic under discussion. I would just like to point out that the nursing home is nothing new. It's the current aspect of a responsibility that the county has assumed since its beginnings. It's the old county farm. It's also related to township aid. So in altering it, we're not inventing something. We're not assuming a new responsibility. This has been with us from the beginning.
Thank you, sir. All right, Mr. Gima from MPA will give us a short presentation.
I can't even see this. Which one do I hit? Right there? Thanks, Rachel. Good evening, everyone. I'm Scott Gima, Vice President or Chief Bottle Washer at MPA. And to my left is Gary Winchell, who is our numbers guy, Director of Financial Services. Because I'll be the first one to admit that I get my debits and credits mixed up on a daily basis. And I won't even tell you what I got in accounting when I was in college. So hopefully, and I know when I've talked with you, I've always said I'm gonna try to keep it short, and I never do, but I'm gonna try like heck to keep this as short as possible. But again, as Al said, please feel free to interrupt with any questions, comments. Just don't throw anything at me. All right, Champaign County Nursing Home, 243 beds. big facility. We are certified for Medicare and Medicaid. We opened a new facility back in February of 2007, and MPA showed up on roughly in July of 2008 to take over management of the facility. What I'm going to talk about in my presentation is basically the 4 topics here. The first is basically an overview of the major payer sources at the facility. Then talk about the issues of revenue or margin versus the mission of taking care of the Medicaid. The third item is what we've done to improve our expenses and what are the future revenue issues that we're going to be dealing with and the opportunities that those issues are bringing to Champaign County Nursing Home. And finally, the last topic will be cash and the cash flow issues that we are currently dealing with and expect to be dealing with later this year. Payer sources for the nursing home, pretty simple. We only have 3, Medicare, Medicaid, and private pay. Medicare is basically a short-term coverage, typically up to 100 days of care per episode. So an episode would mean if you break your hip, that would be considered an episode. If you leave the nursing home, you have to be out of the nursing home for 30 days, and then you can start a new episode of care. Within that, if you end up going back to the hospital in less than 30 days from going home, you're still considered within that original episode of care. Residents who are on Medicare may be discharged from the nursing home back to their homes, or they may transition to a permanent resident stay as either Medicaid or private pay. Medicare requires a minimum 3-day hospital stay, and those Medicare residents receive a very high level of care, both rehab in terms of physical therapy, occupational therapy, and speech therapy, as well as nursing care. The reimbursement for Medicare currently averages, and this is a 2012 average, of $458 per day. That Medicare revenue, which is 8% of our residents, equates to 20% of our revenue. And that was from 2012. Medicaid is long-term coverage for our long-term residents. The reimbursement is the lowest of all 3 payers, and we are paid $151 per day. The rate also includes a $21 intergovernmental transfer add-on. So we have a base rate of roughly $130, but because we are a county facility, we have an intergovernmental transfer arrangement with the state that allows us to get an additional $21. Medicaid represents 58% of the residents. Again, that's in 2012, but it only represents 47% of our revenue. It includes low-income residents or individuals or those residents who were first private pay but have been in the facility long enough that they've spent down their assets and now qualify for Medicaid while they remain a resident at the facility. Private pay is also long-term coverage. Reimbursement for private pay is about $180 per day on average. And private pay is pretty much a one-to-one relationship between residents. 34% of the residents and roughly 33% of the revenue. All right, let's talk about margin versus mission. As has been previously discussed, the mission is pretty simple. We take Medicaid. Usually the first question that's asked for any potential admission is not what is your payer source, but what types of care do you need and can we meet those needs? There are other facilities in this marketplace, in any marketplace in the state of Illinois, that will limit their Medicaid exposure or they will just not accept any Medicaid patients, period. There are facilities that have absolutely 0 Medicaid certified beds, and so they don't have to take any Medicaid. So the margin issue. Again, our Medicaid rate is $150 per day. Actually $151, but I'm using round numbers. Our expenses are roughly $200 per day. in 2012. So for each Medicaid resident, and for every day they're in the facility, we are losing, or we are not meeting all of our costs to the tune of $50 per day on average. So based on the number of Medicaid residents that we had in 2012, the shortfall is over $2 million on an annual basis. And obviously, if we take more Medicaid, that number increases.
When you're saying that expenses are 200 a day, are you just including staff time, or are you including other soft costs such as food?
You know, it's everything, and it also includes depreciation.
Depreciation on the building, or, okay, so that's.
All our
figured into
assets,
this.
yeah.
Okay, so my question would be, since you're figuring in depreciation, and I just want to get this clear, that building was built with taxpayer money, so is that truly a cost that should be reflected in that?
I would argue yes, from the standpoint of, from the IGT standpoint, it's based on that $200 per day, and we are allowed to take depreciation as an expense, a legitimate expense for Medicaid purposes and for Medicare purposes. Now, from a county or public body, that's a different issue, but from our accrual accounting standpoint, it is a legitimate expense that we can take on our cost reports.
Well, and I don't want to belabor this, and I understand that, because you can do that, but I guess when I'm looking at a figure like this, like in private, they've got the cost of the building, their utilities, their upkeep, and everything, which comes into the factor of what it's costing per day to keep a resident. But as I heard Josh talk earlier, you know, the taxpayers have a big seat at the table here with this, and I understand where you're coming from, and I'm glad that the cost is shown there, but I just wanted to know if it was a factor that had to be in there, since they're already, you know, the building's being reimbursed for, basically, and the utilities. But that's fine. That's all I wanted to ask. Thank you.
So what's our depreciation cost?
Mr. Gima, I'm sorry, are you going to answer that question? I have another question from the
No,
board.
go ahead.
Ms. Schwartz?
The depreciation is about 700 something thousand, 750, I don't know, whatever.
Right.
And you have, what, a loss of about 2 million with $50 a day, so you, about 40,000 patient days. So on average, you're taking about less than $20 a day, right, depreciation. So I'm trying to estimate what the cost would have been getting rid of that depreciation. It would still be more than 150. That's what I'm getting at.
Yeah.
So you got 200, get rid of the depreciation, you'll get $20 off on average per day. I mean, not even back of the envelope calculation, more like my head. But, so you're still at 170, I think it's pretty safe to say, forget depreciation, you're still at over 151, is that correct?
Yes, without question.
Mr. McGuire, do you have a question?
I think we're trying to get through this discussion, we're trying to get a better picture of what it costs to run the nursing home, and that's what we're all looking at, because we want to, I feel like I want to make sure it works appropriately. I think Stan does bring up a good question, because really, the building itself is paid for by taxpayer funds and bonds, and most businesses don't have that advantage of having the building paid for, and the depreciation, so having the depreciation there, those costs. So while I don't necessarily mind having the figure there, as long as we understand what we're talking about when we're talking about the cost.
Mr. Richards?
Scott, we've already got ourselves confused talking about depreciation and utilities. What would be your estimate of the marginal cost of every new Medicaid person coming in? So we're getting $151. About what is, we get one new person tomorrow. We will be getting 151 in per day. What will the care for that person, just the flat out care, not broken down by the census, cost the county?
I can't do the math in my head, so you take out the depreciation. I guess the other way of looking at it is what Rachel said. Our shortfall with the depreciation on an annual basis is about $2.1 million. Reduce that number by $700,000, and that's the shortfall that you have.
Thank you. That's a good answer. Ms. Petrie?
I have a number of clarification questions on the figures before we get further along. Just to go back to page 5, under Medicare, you say the reimbursement averages $458 per Medicare resident per day. Is that accurate?
What was the question again, Patsy? I'm sorry.
It's on page, oh, well, you don't have this, but it's on page 5 for the rest of the folks. And it says the reimbursement averages $458 per Medicare resident per day.
Yes. That is correct.
Okay,
Each Medicare resident can have, we have 66 different reimbursement rates under the Medicare program. So each of our Medicare residents could have a different Medicare rate. That rate changes on day 7, day 14, day 30, day 60, day 90, or if they have a change in condition. So it's a very complicated issue, but if you average it out, in 2012, we averaged $458 per resident day.
okay, fine. All right, then back to page 7, where under the margin, you say expenses are $200 per day, give or take the $20 that may or may not be in there with depreciation. Is that apply to the private pay?
Well, with private pay, which is $180 per day, if you take out the depreciation, then it's probably close to a wash, or maybe a little bit of profit with the private pay, without the depreciation.
So for each Medicare individual in the home, on the average, it's $458 minus $180 per day profit.
No. No. $458 less $200 per day in average cost. We receive about $180 per day for private pay. So
Okay.
Medicare, we get $458, private
Okay.
pay, we get $180, and Medicaid, we receive about $150.
Okay, all right, thank you.
Chris?
I guess if I could jump in here, Scott, I think the confusion arises from the fact that the care that's provided for Medicare patients is substantially different than the care that's provided for typical private pay and Medicaid, right? If I understand it correctly, Medicare patients, I mean, having recently been discharged from a hospital, require a substantially higher level of medical service than someone who's there on the long term under Medicaid or private pay who were more in convalescent care. Is that a fair statement?
Yes.
Okay, thank you.
Thank you. You want to continue, Mr. Gima? You remember where you were?
Yes, I do. I actually do. All right, so the mission must be balanced against basically the financial realities of taking care of the residents. So the Medicaid mix at Champaign County Nursing Home has been reduced since 2008. And there was a conscious effort to emphasize Medicare admissions primarily, because again, it's a better payer source. Champaign County will not accept any Medicaid applications or Medicaid residents. Let me try that again. We will not take any new patients who are applying for Medicaid. We call those Medicaid pending. If they're coming from the community, they have to have Medicaid approval, because if we take them as Medicaid pending, we will receive absolutely no payment while we're waiting for the application process to be completed. And currently, that could take anywhere, I think here it's about 6 months. DeKalb County, it could be 12 months without receiving a penny for that resident. Now, we do not have a specific limit on Medicaid, and we will take a Medicare who will convert to a Medicaid. We'll take a private pay, and if they spend down their assets, we will keep them as Medicaid. But I can assure you that there are other facilities across the states that will encourage residents and their families, once they use up the Medicare days or their private pay days, to find another bed in another facility. So here's the changes that we've seen. Now, one of the big reasons why we've seen financial improvement is the very last row, occupancy. We've increased our occupancy from 70% to 82% between 2008 and 2012. We had 169 residents on average in 2008, and in 2012, we're averaging 200. You can see Medicaid has actually gone up. Medicare has remained basically flat, but we have increased our private pay residents, and that has been a big factor also to improve the bottom line. We've gone from 51 residents in 2008 to 69 in 2012. Yes, sir.
Let me, Mr. Carter, did you raise your hand? Okay, go right ahead. You want? Okay, go ahead.
On Medicaid, where is it? Isn't that part of your A and B?
That's Medicare.
Oh, okay, I'm sorry. I'm trying the distinction between the two. I know good and well you shouldn't have any problem with your A and B payment. Yeah, okay.
I don't remember the numbers, but isn't it true that you also, we got improvement in Medicare per day rates? Is it, I mean, this is the dates, but is it also the rate per day that we got better?
It had gotten
I think
better.
2008 used to be pretty lousy.
In 2010, it was really good. It was over $500 per day.
Right,
But when we took the rate cuts, we're back down to where we are now.
okay, thanks.
So when we take a look at the payer mix, or the percentage of Medicaid, Medicare, and private pay, our Medicaid actually hasn't changed much. We're at 58% in 2012. Medicare is 8%, private pay is 34%, and that's based on the number of residents in the facility. But from a revenue standpoint, Medicaid is accounting for less than 50% of our revenue, compared to 58% in 2008. Medicare has increased from 18% to 20%, and private pay has increased from 24% of our revenue to 33% in 2012. So all those factors, the subtle changes in payer mix, plus getting more residents into the facility, has been a big factor in improving the bottom line of the facility.
Scott, I wanted to touch on something that we talked about in our meeting the other day. I think something that board members may not necessarily be aware of, because I wasn't, is that when you discuss margin versus mission, we essentially make no effort to, and by when I say we, I mean you, essentially make no effort to work the payer mix, that we take what we get. And the payer mix that you're showing now is essentially what we're getting. We're not making an effort to, reduce the number of Medicaid beds or increase the number of private pay beds. We're essentially taking whoever wants to come in the door, and that this is more a result of the market conditions as opposed to any affirmative effort on your part to set what you want the payer mix to be. And if that's true, then that, I guess, is something to look at as far as, do we expect those conditions to continue, or is there reason to believe that those will change in one direction or the other as we see the healthcare system evolve?
It is possible that we could end up with a situation where our Medicaid mix gets to a intolerable level. Will it happen? I don't know. All I can tell you is, to date, it hasn't happened, and we can take more Medicaid because of the mix that we have. So if we can get more Medicare, as Josh has said, we can actually take more Medicaid. So that's the name of the game. I mean, all the providers are trying to get Medicare. We're competing against all the other facilities. So if we're successful in getting more Medicare, that does give us much more flexibility to accept more Medicaid. And so again, we have not had to make a conscious effort or decision to limit the Medicaid, except for the fact that we will not take any Medicaid pendings from the community until they are Medicaid qualified.
Just to make sure I understand, I mean, I think what I hear you saying is we're not limiting Medicaid actively, but I think you are actively pursuing the Medicare.
Without question.
Yeah, because I thought what Chris was saying is we're kind of neutral. Whoever shows up at the door is great. And I don't think that's the case. I thought we did a lot, both with the hospitals in general, as well as with the respiratory care and all the other things you described. That
Right,
I
but
think,
I don't have the,
so it's not true that you're not active on pursuing the Medicare, just to make sure that,
I don't have the figures, but I can tell you that 100% of our admissions are not Medicare. We still take private pay, and we still take a lot of Medicaid from the community.
I also think that quality of care and reputation doesn't hurt when people want to come to our nursing home, because that brings people, families who care about their families want to go to a nursing home that has quality care and reputation. And I think we've been able to do that as well. And we've been marketing that in a strong way.
Does payer mix have anything at all to do with how quickly or not very quickly the state pays us?
Medicare, when we submit a Medicare claim, we'll receive a payment within 2 weeks, as long as there's no errors in that claim, missing number or transposing numbers. Medicare pays very quickly. Private pay, when we send out the bills, we typically will get paid within 30 days. I mean, most of our private pay residents are very good at paying. Medicaid obviously is a different story. We're at the whims of the state, and right now we're being paid roughly 2 months in arrears.
Yes, Scott, you have a total of 243 beds over at the nursing home. Is there a certain percentage that you have for the payers, like a certain percent or a certain number of beds for Medicaid, Medicare, and private pay?
How many Medicaid beds are not how many beds are not Medicaid certified? We have 30 odd beds that are not Medicaid certified. So the remaining 210 beds are Medicaid certified.
What determines that?
Do you remember why they did that?
I think when they moved beds, the shelter care and maybe.
There was a licensing issue, and one of the things that we've been working on is to get all the beds certified for Medicaid.
So it's not some physical characteristic of the room or the area of the home, it's just, it has to do with the amount of staffing and that type of a thing?
It's not even that. I really don't recall the exact reason why they did not certify all the beds as Medicaid. But we are going to be working on getting all those beds certified for Medicaid, and we want to certify all the beds for Medicare.
Any other questions at this point?
Okay, the next topic, expense improvements, future revenue issues and opportunities. So besides increasing our census, seeing an improvement in our payer mix, we've also made substantial expense improvements since 2008. And no surprise that labor costs are, roughly 50+% of our expenses. And so we've done a lot of work on labor costs. We've reduced our staff turnover. We've improved our workforce by trying to reduce the number of poor performing staff, improving our hiring practices. We have made significant improvements in reducing our agency use. And on the non-labor side, we introduced back in 2008 a number of new pricing structures for our major supply costs. Number one would be our therapy provider contracts, pharmacy, and food services. And on an ongoing basis, we do a quarterly review of our purchasing behavior. We do belong to a purchasing group, and they'll come in on a quarterly basis and check our purchases against their contracts to see if there's any opportunities to reduce our expenses. And I think you've seen this chart before for our old board members. Contract nursing monthly expenses. So this goes all the way back to December of 2008. And these are our monthly expenses for agency nurses, which would be RNs, LPNs, and also CNAs. So back in 2008, we were spending well over $150,000 per month for agency staff. I can't even tell you how many actual nurses or CNAs that was, but it was a lot. And we've gotten down to November, we were down to about little over, I think it was $44,000 for the month. So we have made substantial improvements. We basically do not use any agency RNs or LPNs for the most part. What we are spending our contract nursing costs are on CNAs. But we have reduced our turnover just this past year. We have seen an improvement in our CNA turnover rate. And that's one that's always going to be difficult, but we have been able to actually retain more of our own CNAs over the past year.
Yeah, do you have a target level that you're trying to get that to, besides zero? Okay.
No.
And is there a realistic level that we're trying to get to?
I think right now we're doing pretty good. It's like losing that last 10 pounds that you want to do. It's going to be the hardest. So can we get it down to zero? It will be tough. And my guess is that you're going to see fluctuations throughout the year. And around the holidays, we're always going to be using more contract nursing. But we are trying very hard to retain our staff, keep them around. But again, the CNAs typically are your younger employees just out of high school, and they're living paycheck to paycheck. And so we're always going to see a lot of turnover in that job category, unfortunately.
I guess I would make the point that the ideal level is probably not zero, because it's good to maintain relationships with those agencies. Obviously, it's always nice to be able to pick up the phone and call somebody, even if it costs a little more, if we do have a number of people who are out sick, or we do have a change in the census that requires us to ramp up quickly. So I guess I don't feel bad that it's not zero. I think it's great that we've managed to cut it in half.
Future reimbursement issues. So last October 2012, I'm going to say we got lucky. We actually saw our Medicare rates increase by 1.8%. But of course, that could be short-lived. The fiscal cliff discussions that occurred had a 2% rate reduction hanging over our heads. Luckily, come January 1st, we didn't see a 2% cut. But again, we've got the new fiscal cliff discussions being had in Washington, and the 2% rate cut is on the table as a possibility come March. So the glass half full viewpoint of that is that a 2% cut for us would equate to roughly a $53,000 annual loss in revenue. So that's something that we can absorb. Medicaid rates, that $151 is frozen until January of 2014. We were supposed to see a new rate methodology implemented on July 1st, but that was postponed. That new rate methodology will increase our Medicaid revenue by roughly $500,000 on an annual basis. So our associations are going to try and get legislation to implement the new rates sometime this year, but I'm not holding my breath, but it is a possibility. But on January of 2014, we could see our Medicaid rates increase. Looking ahead, we've got a rapidly changing marketplace in the long-term care industry. It's unprecedented. Josh had mentioned hospital readmissions, but we also have what I'm considering a huge change in the industry, which is the state wants to put together a managed care demonstration program for our dual eligibles. Dual eligibles are seniors who are covered by both Medicare and Medicaid. And that basically is any Medicaid that we have in our building is a dual eligible, because just about every single one of them is also covered by Medicare. The reason why the state wants to do that? To save money. They would give a health plan, Health Alliance is one in our region, a capitated payment, a fixed payment per member or per person per month, and it's up to Health Alliance to take care of that patient, whether they are in the hospital as Medicare, in the nursing home as Medicare, or in the nursing home as Medicaid. So the goal is, again, is to save money, but also try to improve the coordination of care. There are inefficiencies in the way we care for our patients and the transition from hospital to nursing home or to home. But this is also an opportunity for high-quality or high-performing nursing homes, and especially for Champaign County Nursing Home that accepts Medicaid without question. So other homes that actively limit their Medicaid, the hospitals know which homes those are. And we've already had discussions with both hospitals, and they know that we're taking the Medicaid. And so that's an opportunity for us to get more Medicare market share with these dual eligibles. And on paper, the state wants to get 50% of these dual eligibles into a managed care program by 2015. But HFS has also made it very clear that they'd like to see 100% of the dual eligibles in managed care program by that time. So it changes the incentives, because right now for Medicare, we want to get more Medicare in the building, but we want to keep them on Medicare as long as possible and provide as much therapy as possible, as legitimately possible. We want to increase the length of stay, because the longer we keep on Medicare, the more revenue we're going to get. But if the health plans are being paid on a capitated basis, they want to look to providers that have the best outcomes at the lowest amount of cost. So if it takes, right now, and I'm just making these numbers up, let's say our average length of stay to rehab a broken hip is 68 days. If we can get that down to 55 days with the same outcomes, the health plans are going to say, I think I want to send my hips to Champaign County Nursing Home versus another facility whose length of stay is 100 days. And so these are the initiatives that we are implementing or looking at to try to position ourselves for this managed care playing field. Renal dialysis, respiratory therapy, which has started up just last week on the 22nd. I believe we have at least 10 residents that are being seen by a respiratory therapist. We actually have been talking with a pulmonologist from Provena who is willing to start a pulmonary clinic and actually do rounds with our residents at the facility. That will be a huge, huge benefit for us. Medical management, what that means is how our physicians and our nurse practitioners are seeing and treating our patients. So we are trying to ramp up our medical management, especially with our Medicare patients. What that means is we'd like to see our nurse practitioners to see those patients on a daily basis so we can pick up on subtle changes in their conditions so that we can implement nursing interventions or whatever to prevent them from going into the hospital. And nursing case management is basically an augmentation of the medical management where we have a dedicated nurse who's also going to watch over these patients, both Medicare and non-Medicare, to pick up on these issues as quickly as possible, follow through on lab tests, radiology tests, basically to make sure nothing falls between the cracks.
Yes, Scott, I seem to recall we had our max census fairly recently, which was 216, 200?
We were roughly 214, 215.
Okay. And we have 238 beds.
243.
43, okay. So at one point in this list of things, possible things to do, there was a talk of taking a few of the rooms and making them singles to make them more attractive, I think probably to private pay options. And I don't know that that ever went anywhere. Was there a reason why it didn't go anywhere? I mean, with all the rooms that are beds that we don't have used, it seems like it's still an interesting idea.
We did convert about 5 rooms to
Okay.
private pay. We also have some residents that came over from the old facility that we're also keeping in private rooms, and some of those, just less than a handful, are actually Medicaid, but they basically were grandfathered in. And we felt that that was necessary. We didn't want to burden them by putting them with another patient when they've been in a single room for years.
So our 243 capacity is not our real current capacity. There's, sounds like 10 or so beds that are not really there because they're singles.
I'm going to guess realistically, we're talking about 220, 222, and that's an educated guess on my part.
Yeah, when you go to single rooms, is there a change in pay, or do they pay the same as double occupancy?
We do have a private room rate for private pay that will generate a little bit more for that bed. But if we take a semi-private room, which has 2 beds in it, into a private room, then we're losing the opportunity to fill both beds. But if our census is always low, there's no reason why we shouldn't make a semi-private into a private room if we can put someone in there on a private pay basis. So the other thought has been to take a look and doing the same thing for our Medicare residents, our short-term stay, because they typically are going to be younger, and especially those that have the potential to go home, that it's more attractive for those residents to come to our facility if they will have a private room. But when we hit our census, of 215, which we've never seen before, everything stopped.
This is going to sound like a really dumb question, but does someone who's discharged from the hospital and who is going to be covered by Medicare get to decide where they go, or is that up to the hospital?
They do have the decision of where to go to.
So the patient hasn't, so essentially marketing ourselves to the community is valuable potentially not only for attracting private pay patients, but for encouraging people who are being discharged from the hospital to elect the county home as opposed to another facility.
Yes.
Thank you.
All right, let's turn to cash flow. So I just want to make a point that there's 2 different issues we're talking about. The financial position, or are we living within the tax levy, are we breaking even, or making a little bit of profit? That's how I define financial positioning versus cash flow, which is actually getting paid for the services that we've rendered. So from a financial standpoint, we have made substantial improvements since 2008. Cash flow, obviously, is a different story. So what has happened over the last few years with cash flow? I talked about that intergovernmental transfer program. Well, back in October of 2009, the state stopped all IGT payments because the federal government said that the state needed to restructure that program. It took over 2 years before the state finally got a new system in place. So we basically did not receive any IGT payments between October of 2009 through December of 2011. So we finally received a lump sum payment of roughly $1.2 million in December of 2011. Then to add more fuel to that fire, we had the Medicaid payment delays, which started in July of 2011. And so we initially were not paid for 6 months. So again, we had no Medicaid payments between July of 2011 and December of 2011. In December of 2011, at the same time when we received that IGT payment lump sum, we were able to get Champaign County classified in an expedited facility, and we reduced our payment delays from 6 months to 3 months. So we also received roughly $900,000 in Medicaid payments between December and January. So we basically had a cash infusion of about $2 million. So when we stopped receiving that IGT payment for 2 years, we gradually ended up with a very poor cash position for the home. And as a result, we actually delayed paying our vendors, some of our vendors up to 12 months without a payment. So when we got those lump sum payments, we paid down roughly $2 million in payables from December 2011 through the rest of the year. And we are currently about 2 months behind in paying our vendors, on average. Some vendors we pay right away, others we don't. But on average, we're about 2 months in arrears.
Scott, how many of those vendors charged a financing charge on that delay?
About 3 or 4. So there was a lot of communication that was going back and forth. So probably the biggest one was therapy. I mean, we went 12 months without paying our therapy vendor, and we owed them, it was a seven-figure number that was outstanding. And they really were very accommodating for us. This chart here shows our monthly changes in cash accounts receivable and accounts payable starting back in July of 2011. And so you can see, leading up to December of 2011, our payables was up to $3.62 million. And then now we've got it down to roughly where we are in November of 2012 at just under $2 million. So again, Medicaid is currently paying us roughly 2 to 3 months behind. We are and have been receiving regular monthly payments. So, and that is not a typo. I put that in there because 3 months ago I said delays are likely. Now I'm saying delays will occur because that's what all my sources are telling me. It will happen in 2013, and I've been told maybe as early as March, because one of my contacts says that he believes that the state is going to start running out of money in March, and we'll have to start delaying payments even further.
Was there any particular time frame on how long these delays will occur?
No.
Thank you.
Can you go back to the graph slide? I mean, I'm saying what you already said, but just the point about the income versus cash flows, at any point in time, your receivables exceed payables. So for people to see, I mean, as much as we owe money, but and obviously when you add the cash, it's more than that. But if what was owed to us would have been paid, we have more read the receivables. What we are owed is, in any given point, a lot more than what we owe.
Yes.
So it's a matter of timing of when that payment comes in. I'm not telling you, man.
So again, I think it's almost guaranteed that we are going to see an additional payment delay sometime in 2013, and the magnitude of it is absolutely unknown. I mean, so what we've done in preparation is you should have a cash flow projection that we have put together. It includes actual cash payments and disbursements starting in July of 2012 through December of 2012. And then from January of 2013 to December of 2013, we are projecting out our cash payments and outlays for the year. Now,
Just let me stop you there. You do not have that, that sheet yet. Deb is going to get that sheet for us.
oh. So the cash flow projections, what you will see, it shows, is basically based on our historical cash outlays and disbursements, what we anticipate it's going to be for this year. So now what you're going to have in front of you includes the status quo. If Medicaid payments continue, we will actually see our cash increase from the current level of just under $1 million as of November of 2012. We will actually increase our cash to $2 million by December of this year. But again, I know it's a false assumption that everything remains as is. Regular payments, no Medicaid payment delays. But if we were so lucky, it shows, based on the budget that I had put in place for 2013, we will actually increase the cash balance for the facility. The projections also adds 2 scenarios. One, Medicaid payments will stop in March of 2013. And based on, and that's roughly a loss of $300,000 in revenue, or in terms of payments per month. And if that happens, cash will depleted by June. And then again, that's if we do nothing else. Just Medicaid payments stop and we continue to pay all our bills as we are now. Because right now we're paying, our payables average between $600,000 to $700,000 per month. So the other scenario is if Medicaid payments stop in March, but we also reduce our payables by $200,000 per month. So instead of paying $600,000 to $700,000 per month, we're going to pay $400,000 to $500,000 in payables per month. And that will get us through August or September. So instead of June, where we run out of cash, we can make it through August or September. But again, that's predicated on how reasonable our vendors are going to be if we do that.
Mr. Kibler.
Thank you. Regarding status quo, just to understand the $2 million, I believe last quarter we provided revenue anticipation notes of around $800,000. Is that $2 million including another round of revenue anticipation notes by the end of this year? So in essence, it's really $1.2 million, or this is purely by cash flows other than revenue anticipation? Thank you.
Yes. So again, the only option that the nursing home has to conserve cash is to hold back on payables. So can we, if we can actually hold off paying $200,000 per month, it gets us through August and September, and at that point, we're starting to reach close to 11 or 12 months again in outstanding payables by that point. So again, it will be predicated on how flexible our vendors are going to be. And we've already started discussions with our vendors about this and to see how amenable they're going to be.
I know you like to give us the most conservative, how horrible can it get? But in the past, when things were bad, how far behind did the state get?
6 months is where we're at right now. Not for us, but with other nursing homes, 6 months.
Okay, so going behind on payables, which is not something we haven't done before, gets us roughly to the 6, 7 months where we will, I mean, it's not like they'll stop paying period, because if they'll stop paying period, you can close the door. I mean, right, so.
Yes.
I mean, even you won't say that they stop paying, never will pay.
Right.
So I know that you don't want to tell us how long they'll be because you don't know, but just from what we know, when things were bad and we didn't get the expedited payments, we were roughly at 6
months.
Okay.
So you're saying your hardship is coming from this, the state is not paying that part of the bills on time? Okay.
Yes.
All right.
So MPA has been working on trying to insulate the county, Champaign County, and all county homes from cash flow issues. So we've been working on 3 different options. One, is what I call our ace in our hip pocket, which is getting the governor's office to make a policy directive to make sure Illinois County homes are paid on a permanent expedited basis, or at least on a regular basis. We can live with a 3-month delay. As long as we receive regular payments, we're okay moving forward. The second option, obviously, is to conserve cash by delaying payables. And no one really wants to do that. But that's the only option that the nursing home has itself. The third option is the revenue anticipation notes, which Gary will talk about in just a second. Now, going back to the state policy directive, we've been working on this for well over a year. We've been talking with the Illinois Comptroller's Office, the Office of Management and Budget. I think these are things I've told you guys before, and with the Governor's Office. And so I'm pretty optimistic that we will be successful in this, but they have not pulled the trigger, so to speak, because there's no urgency, because we are receiving regular payments, and right now the state's got bigger issues, i.e. the pension that they've been dealing with. But we have already started our think sessions with our contacts in Springfield to get ready for, as soon as we see that there's a payment delay looming on the horizon, then we're going to be spending more time in Springfield and talking with the governor's office. So again, county homes are a different beast from any other nursing home in the state because we do not have the same access to cash that everyone else has. We can't go to the bank to get a working capital loan. The only option that we have is the revenue anticipation notes. But revenue anticipation notes have to be paid back within a year. So it's not perfect. We also do not get any interest payments if the state is late in paying us. And last year, the state actually paid out that 1% per month interest to everyone else. But because we are a local governmental body, we are exempt from receiving interest payments. So we are really on a different playing field. And again, the comptroller, the OMB, and the governor's representatives all understand that. Now, can we get them to pull the trigger? It remains to be seen, but I do feel fairly optimistic that we can get it.
I feel more comfortable being proactive than reactive. So is there a consortium of county nursing homes that you maybe could go in and talk with the legislators today and being able to maybe craft something in legislation that would allow county nursing homes to be at the front of the line versus waiting until you see something that might not?
Right now, my understanding is there is possible legislation that would require Medicaid to issue their vouchers immediately. Because right now, the way the game is played, if we have a 3-month payment delay, HFS will not generate the Medicaid voucher until the 3 months has come up. They don't generate the voucher and just give it to the comptroller and let it sit aside. That's the way that HFS can control what's getting paid. If they're required to issue those vouchers immediately, the comptroller has been very, very helpful in getting us payments. So when that voucher has been received by the comptroller has been putting our vouchers for county homes on the top of the stack. And that's why we're getting paid roughly within 2 months instead of 3 months over the last few months. So with that legislation, I think we will have much better ability to get paid on a regular basis. But it has been discussed about whether to get, and again, we're getting into politics, which is obviously not my forte, but the experts that we've been talking with said that that's not the approach that we can take, because basically all it requires is a phone call by the governor to HFS, and it'll be taken care of. It doesn't require legislation. It's just a change in directive by the governor's office, and we're good to go. But that being said, we are working with the County Nursing Home Association, Life Services Network, which is our not-for-profit nursing home organization, and also with Metro Counties and their lobbyists. So all the collective bodies that we have are putting forth the effort. And I actually have a meeting with HFS next week, Tuesday, to discuss this and other matters.
What is the barrier for county nursing homes to get working capital loans?
State statute prohibits local governmental bodies from getting working capital loan at a lending institution.
So is that an avenue that you are approaching our legislators about, since it's state statute?
No.
There has recently been a Senate bill introduced which would enable lines of credit for counties. It's stuck in committee. I haven't seen an update lately, but the legislation has been proposed.
Thank you. So that's something to work on, lobby.
So you've got the cash flow projections in front of you, and obviously there's a lot of detail in there because we actually put in there anticipated Medicare, Medicaid, and private pay payments, payroll, as well as accounts payables for every month. All right, I'm going to turn it over to Gary, and he's going to give you a brief overview of the revenue anticipation notes.
All right. Revenue anticipation notes, referred to as RANs, is an attempt for the home to borrow in the short term without being a burden to the county. That borrowing would allow us to pay our vendors and be more timely, thus keeping better relationships with them. As we mentioned, conventional ways were prohibited currently, but the RAN does allow us. It is short-term though. It's got a 1-year maturity. It's based on 85% of the anticipated revenue, which in this case is the Medicaid receivables. Interest rate is estimated at 2 to 4%. But again, the payoff is the revenue source and not taxes, not other methods. That's the goal. But again, I'll address this, but it's a short-term 1-year financing vehicle. The county will approve the increments, whether they want it quarterly or annually. Monthly was cost prohibitive. The banks we talked to and the different lending institutions, between the administrative costs and attorney's fees, the monthly option at the dollar amount was cost prohibitive, so they are looking more for a quarterly package at a minimum. The collateral for the RAN, again, as I mentioned, it's the Medicaid accounts receivable as reported by HFS. We have to be able to provide what our anticipated revenue is. HFS gives us a report monthly on about the 20th for the preceding month. That's the dollar amount we're looking at as the anticipated revenue. When we get 3 months in hand, we have our quarterly package, and that's when we'll be able to take out a RAN. I mentioned that it's a vehicle to have the home try to pay its vendors on a timely basis, but it does have to have a Champaign County guarantee. Now, that guarantee doesn't really go into effect until maturity. Hopefully, before that happens, the state will pay. We talked before that we've had a 6-month delay. I'll get into the numbers on the next slide here. But the guarantee is required because if the state withholds payments beyond a year, the home really wouldn't have a method to pay, and the RAN is required to be paid within 12 months. There's no extension. So again, we're kind of handcuffed there also. But it is a vehicle in the short term for us to try to take care of the home's needs.
How badly does that interest rate cut into your very low margin?
It doesn't help, obviously, but nor would it be to lose a number of vendors and have to have them replaced. Because again, I've also heard, and we also find that quality is what we're looking for also. We want a quality nursing home, and we want good vendors. So we want to make sure that we maintain those relationships. So it would be a necessary cost, and we would account for it.
This is not something we're currently doing, so can you explain which one of the bleak scenarios you're thinking about, would that be necessary?
I think this would be necessary if we do fall within 3 months, and the indication looks as if it'll go further.
Okay.
So that would be an immediate need. Right now, we're 2 months behind. If we fall 3 and the indication that they're going to withhold for 4 to 6 months, I believe it would be necessary.
So how come in the past we were able to get through with 6 months?
Right, again, it's going to be predicated on how far you're going to be comfortable in us pushing back or holding back on paying our vendors.
Right.
So we can push the envelope, because we've done it before, and we're willing to do it again, but it becomes a board of directors and a county board decision of where you're going to feel comfortable with. You know, do you want us to go 12 months before you want to talk about RANs, or you want to do it sooner than later? So we have the flexibility of playing the payables game to buy time.
To further that, the issue also is there's a bit more risk at this point. Vendors that it's extended out 9 to 12 months in the past didn't know it was going to go that far, that we went month to month. Some of the vendors now, once we get to 3-4 months, will they extend that credit to us and go to 9 months, go to 12 months? Again, it happened once, will they be willing to allow it again? So there is some risk in doing that.
Mr. McGuire, then Patsy, then Chris.
Well, I guess I need to understand how this process will work and how will we have to tell you it's okay to borrow the money, those types of things. But then I need to understand too, the state doesn't stop the payment completely, they delay the payment. So what dollar that's asked for today may not show, they may not pay it for 4 months or 6 months, but eventually they'll pay it. And once they catch that up again, they're making just a late payment continually. So the cash flow continues. It's not that it stops.
That's true, but if it is delayed for 6 months, what would happen if you take out 1 to 2 RANs? Hopefully, they will not go any further, but again, there's no guarantee. But as soon as they start making payments, you start paying down the RAN. And that's why I said, as long as it stays in the short term, the home can settle it themselves, because if you have 3 months in hand and it's got a 1-year maturity, if they only go out the 6 months, it'll actually pay off the RAN, and it'll never approach the guarantee point.
Right, but how does that trigger? Do we trigger that payment, or is it just totally up to the nursing home to make those decisions about when that payment's made and how?
Actually, that's within the RAN document itself. As soon as the funds are received, it has to pay it down. So as soon as Medicaid pays, the RAN will be paid down.
Patsy?
Last time we talked about this option, there were not dozens of banks knocking on our door to facilitate this. Has this changed?
It's the second line item up there, the Champaign County Guarantee. When we first went out to market, with the treasurer here in the county, we were trying to do it without the guarantee, so they weren't knocking on our door. And actually, we were hoping that it would not be a requirement, but we did talk extensively with bond counsel, and since it does mature at the end of a year, there has to be a payment source. And if the home itself, if the state withheld for 1 year, the home wouldn't be able to make that payment. So the lending institution's looking for some form of guarantee, and that's where the county guarantee would cover that.
Thank you for the explanation.
I guess I would just, when I look at this, and we talked about it before, I guess the first thing I look at is we've already gone out on tax anticipation warrants. We've been doing that now 3 or 4 years. So that means we're out on that ahead of the game. So when that comes in, we're already a year behind with the money that we've already collected. So now we're asking for these notes. And basically, I just feel like that's what's happened with the state. They keep borrowing to pay Peter, to pay Paul, and then the funds don't come in or the revenue source doesn't come in. And I know some of our budgets have been very tight and there's been very little activity in upkeep and other things that, you know, our buildings need and what have you. Plus, I hate paying interest. I hate it. You know, I don't care if it's 1%. You know, they're not going to give us that on our money when we put it in the bank, but what you're saying here, and if I remember correctly, when the treasurer gave us his report on the anticipation warrants, and he's here, he could correct me, but I think over the life of those so far, we've paid like 30-some thousand in interest. And if we're already hurting, and even though we're borrowing money to pay people, I guess we need to really look at it and work at it like we did before. If I can't pay my bills, you know, I work with the people I owe to, I'm not going to go out and extend myself more, because eventually I'm talking bankruptcy and everybody hurts. And I don't like the idea of the county, especially as precarious as times are, and they're going to probably get a little shakier, and they have been for a while. I haven't seen a good year blimp for years. I just don't like that. I think that what you're saying is fine, but now the kick is, and Patsy asked the correct question, is the county's going to have some sort of funding, and basically that's going to be general corp, I'm assuming at this point, because I know the sheriff isn't going to give up 18 squad cars so we can pay these bills. But with the state being in the bind it is, and every day I turn on that radio, and I'm not a fearmonger by any means, but every credit agency is lowering our credit rating, so they're going to be borrowing money with higher interest. I just think that when we look at the big picture, we've got to cut it off. And at this point, until I hear some more good news, maybe if the staff decided they were all going to kick in 10,000 to a pot or something, which I don't believe is going to happen, that would help, you know, send that off. But I just can't support borrowing money to pay money with an interest rate.
That's a good point. Keep in mind here, though, that it's not the result of operations, it's the result of the state withholding payment. So it makes it a little more unique in that regard, because a lot of those funds are federal funds, so at some point in time, and again, we'll get to the likelihood of it going out 15 months in just a minute here, but for the likelihood, it doesn't seem that it will. And because you're borrowing for something that's part of, it's to fund a payer source that you want. Scott went through the payer sources. Medicaid is something we want at the county home. It's not through operations that we're short of cash. That would be a difficult situation, and why would you borrow? This is one of your payer sources have stopped, and it's the state.
That's what scares them.
Well, I understand.
Well, I guess to finish that, I would say that, like the census, because you said that a lot of this is going to be based on what the numbers are and when it comes in and when you borrow it. But as we've seen before, that census can take a heck of a nosedive. And with the state, and probably the same people you've all spoken with, some of the state legislators I've spoke with, they've got this retirement thing that's really going to hit them. And we already see what they're doing with schools. So I understand the crunch you're in. I understand if I was a vendor, I'd be wanting my money. But some money coming back to me and being delayed with the promise it's going to be paid is still a lot better than us borrowing money and going further in debt with some interest.
I'm sort of have an observation. I can't figure out how the state breaks the law and we have to follow the law. In my experience on if you employee, you have to have a tax account. That tax account, you can't use that for nothing but the taxes. And when you get down to that, you broke, but you don't bother those people's money. And what I'm getting at, how do they go in and opt out pension money and money that they owe the vendors and everybody else do business with them? How they get around that? Why ain't that money put in the same like tax account when you're a business person and you can't use that money. Or even a building from your church, you can't go into that. It's building fund. That's the only thing it can be used for. But the state and these other government agencies can go and spend that money and get away with it. I can't understand that.
Patsy, did you have something? Okay. Thank you. All right. You continue, please. This is a long 15 minutes.
Okay, how bad does it have to get? That's sort of what we're talking about. As I mentioned before, you have to package 3 months together. The RAN has a 1-year life. It would have to go 15 months before the county would actually have an exposure. And then even at that point, they would still have the accounts receivable.
So again, the magic question is, could we see a 15-month payment delay? And basically, we would be entering in, we're in uncharted waters. Who knows what's going to happen? But history says right now, we've gone 6 months. And again, nursing homes don't, in general, do not have deep pockets like hospitals do. Because some hospitals are out more than a year with some of their payments. But nursing homes just can't weather that kind of payment delay. So from a policy standpoint, if the state would withhold payments for 15 months, it would put just about every nursing home in the state out of business that is taking Medicaid. So from that standpoint, I would say the risk is very low that we would see a 15-month payment delay, which would then require the state to pay off the revenue anticipation notes.
I'm trying to process some of the preceding data that you gave us on page 10, where you talked about the Medicare rates increased in October, could potentially decrease more than the increase, and that presents a $53,000 loss. Then you go on to point out that Medicare rates are frozen until January of 2014, but there's a potential.
Medicaid rates.
Medicaid, isn't that what I said?
No, you said Medicare, sorry.
Oh,
Medicare
sorry,
rates.
thank you. $500,000 annual increase with new rate methodology. When potentially will that $500,000 increase come into play?
Again, that new rate methodology would start on January of 2014. So on an annual basis, we would see our Medicaid revenue increase by $500,000.
Okay, so if we were in this worst-case scenario of not getting paid for 15 months, and we're in January now, and say we don't have to do these type of bonds, say until March or April, and therefore 12 months, that means January would have rolled around of 2014, and we have a potential of an increase of monies coming in under the Medicaid rates. Am I understanding correctly?
But there's a difference, or need to make the distinction. Our revenue goes up, but we still have the question of when we're actually going to get paid that additional revenue.
Right.
So we will increase our potential revenue that we're going to receive from Medicaid, but we're still going to be living with the question of when the state is going to pay us any or all of that Medicaid revenue.
Okay, and I guess one last clarification question. Are there delays to the state from the federal level of the money coming into the state, or the clog is here in the state?
It's the state.
Okay. Thank you.
I don't have anything new to say, except I understand that from a financial perspective, it's responsible to play with what-if scenarios, but I do want to, the problem is once you put out a scenario, people tend to focus on that. And like you said, if the state will delay for 15 months, which it never did, by the way, because when it did, it was 6 months, no nursing home will survive, therefore it will never delay for 15 months, unless we want to shut down the state, which I suppose is a possibility, but not likely. So I just want to be careful that, I appreciate your putting out all these worst-case scenario, what could be, what we should think about as what possibly we would be doing if these should show up. I just want to make sure that we don't end on that point of, oh, that's what's going to happen, because that's kind of what it sounds like. I know that's not what you were trying to say, but I'm sure the newspaper headline might say something to that effect. So I just want to make sure that we understand the reality as opposed to, well, there is a zero probability event that all nursing homes will shut down, the jails will shut down, the state will move to a different state, and so on. I mean, we can talk about all kinds of things, but do we really want to put that out and talk about it so seriously and then leave us with the impression that this is an imminent? I just want to make sure that's not the case.
So I understand what Rachel is saying, because, and I've heard this before from, with my other homes, that I'm always all doom and gloom. And unfortunately, that's kind of what we're dealing with. But at the same time, we've gone over potential solutions to address that problem. And yes, I understand the revenue anticipation note is nothing that, no one wants to do that, but it is an option that's out there if necessary. But again, the ace in the hip pocket is getting the individuals in Springfield to make a policy change. And I am very, very hopeful that that will take place. And if we are successful with that, then we're good to go, and all this other stuff goes into the trash. So, but again, it's a wait and see position that we have with the governor on this. They basically said, get back to us at a later date. So, but we are primed and ready to go as soon as we see that payment delays are coming down the pipeline.
All right, are there any further questions? Mr. Kibler, then Mr. James.
I just want to verify that, Scott, you will be around during the operations discussion that we may be having a little bit later.
I'm sorry, I can't hear you.
That Scott will be around during the operations discussion that will be happening later, because I have questions more related to that, and I don't want to lose him if he's going to leave.
I'm not going anywhere.
They're not going anywhere. We've locked the doors. Stan?
Scott, refresh my memory, with that influx of supposed cash we may get, that increase, wasn't there also going to be an offset with a bed tax?
That already took place last year.
Okay.
Okay, thank you, gentlemen. I really appreciate your efforts here. Thank you for giving us both sides of the story, the Armageddon and the positive. But I think we're somewhere in the middle, and I think you've done, in my opinion, and not necessarily the boards, but in my opinion, you've done an extraordinary job of turning around what was once the Red River, if you want to call it that, and bringing the nursing home in what I consider to be one of the top flight nursing homes in the state of Illinois. So thank you. We really appreciate your efforts. The next gentleman up is going to be Mr. Chris Alex. Microphone, Chris, please.
The world seems to have turned pink here. I wonder if we can. I guess we'll just go with pink.
Go, Chris, go.
There we go.
Oh, the right hand.
Yep.
Okay, thanks, Al. I circulated a memo, which is included in the packet, which talks about many of the things I'm going to say, so I'm really just going to hit the highlights here. I'm going to talk a little bit about financial history, the nursing home, sort of how we got to the point that we're at from the standpoint of funding. I'm going to actually recap some of the points that Scott talked about very briefly to sort of put these things in perspective in the overall county, and we'll go from there. Again, this is not an exhaustive overview. I'm not going to go line by line through the budget. The nursing home board of directors sees that every month. Scott comes to us quarterly and presents that. So I want people to sort of think of this as a more of a top level overview. And the goal here, I think, is to get to a shared understanding of what the actual financial condition of the nursing home is. To start with 2003, I'm sorry, I'm having the microphone's a little cutting out. Can everybody hear me okay? Okay. In 2003, in November 2002, we had a referendum, and the wording of it's up there. Shall Champaign County construct a new Champaign County nursing home building and make and acquire related improvements, facilities, fixtures, furnishings, and equipments? Issue general obligation bonds in the amount of $20 million for the purpose of paying the cost thereof. And that was approved by a substantial margin, which I think is something that we need to keep in mind. At the time, the citizens really wanted to build that new nursing home. So we issued bonds in 2003. We issued about $20 million worth. They were refinanced in 2005 and 2011. The annual debt service on those bonds, principal and interest, is about $1.4 million. There's a dedicated property tax line that goes to that debt service. Whether we had a nursing home or not, we would still be paying the debt service on those bonds. And both the debt associated with those bonds and the revenue that goes to pay them is not on the Champaign County Nursing Homes books. That's essentially taken care of by the county, paid for by the taxpayers, and they'll be paid off in 2022, and at that point, the tax levy will go away. There's another referendum that was passed at the same time in 2002 by also a slightly smaller margin, but still a substantial margin, which was shall Champaign County be authorized to levy and collect a tax at a rate of 0.03% for the purpose of maintaining a county nursing home. That generates about $1 million a year. Again, that's a separate line on your property tax bill that is listed as nursing home. It's permanent until we decide to change it or repeal it, and it's 3 cents per $100 of equalized assessed valuation. I'll come back to this a little bit later. In the, what I guess we could call the bad old days of the old building and before MPA, the General Corporate Fund made a significant dollar contribution to the nursing home to tide us over, keep things afloat until the new building was online. And I just include this for historical completeness, and I think to make us feel good that we're not having to do this anymore. Most people in this room are probably aware that the $19.9 million bond issue did not cover the actual cost of constructing the nursing home. The construction project ran into some problems with mold remediation at the mold at the construction site, which had to be remediated. There were some problems with the heating, ventilation, and air conditioning systems, and all in all, it ended up costing about $4 million more that we had to pay to get the building finished. So the county didn't have a whole lot of options there. What they did was they issued $4 million in bonds. Those were backed by a portion of the 1% sales tax. The debt service on those is about $307,000 a year, and those will be paid off in 2026, a few years after the original construction bonds. And for the first 3 years of those bonds' existence, the General Corporate Fund paid the debt service on those, paid the debt service on those bonds. First payment was interest only in 2007, and then it paid about $300K in 2008 and 2009. Of that 2008 payment, almost all that money came from settlements that were reached with 2 of the contractors involved in the construction. So that helped pay for a little bit of that. From 2007, when the home opened, to 2009, instead of grants, the General Corporate Fund made a couple of loans to the nursing home fund to help with operational shortfalls. It was $360,000 in 2007 and another $972 in 2008. So there was a total balance at the end of those loans of about $1.3 million. And this is where it gets a little bit complicated. In 2009, the county, the General Corporate Fund, in fact, received about $1 million in settlement from Farnsworth Group, which was the contractor that had designed and installed the HVAC system at the new building. When the General Corporate Fund received that $1 million, because that was essentially a reduction in the construction cost of the nursing home, the General Corporate Fund forgave $1 million of that $1.3 million loan balance, reducing that loan balance to $333,000. At the same time, the nursing home fund assumed the responsibility for the debt service on that $4 million loan. So before, the general corporate fund was paying the $307,000 a year, and the nursing home fund took that over. They have, for the last 3 years, paid that, so about $307,000 a year. That says expected, it should say expensed by Champaign County Nursing Home annually, and the remainder that is still outstanding of that $4 million bond debt is actually carried on the nursing home balance sheet as a long-term liability. Just a couple of comments about that. We have this kind of strange situation. The $20 million construction bond doesn't show up on the effects of the $20 million construction bond doesn't show up on the nursing home balance sheet, and the nursing home doesn't pay the debt service on that, but the $4 million bond does. So essentially about $307,000 a year of the nursing home's expenses are attributable to, and actually it's not, even that's not entirely correct. The interest portion is taken as an expense. The remainder is essentially revenue neutral to the nursing home, but it does have a cash impact. So as you look at the nursing home's books, you're gonna say, hey, why is this on here and the other one isn't? And I think I've expressed a little bit of the history as to how we got here, and it's something to keep in mind as you evaluate the financials. Another issue which has come up a couple of times recently is this issue of how the 2009 agreement, which, to refresh your memory, is the nursing home agreeing to take over the debt service on those bonds, affects the outstanding loan balance. As of now, officially, we still show a $333,000 loan balance due from the nursing home fund to the general corporate fund. However, the nursing home for the last 3 years has paid $307,000 that the general corporate fund would have had to pay if the nursing home hadn't been paying it. So I think there's a strong case to be made that that was equivalent to repaying the loan. It's also worth pointing out that the nursing home fund is on the hook to pay about $5 million in total through 2026 if it indeed sees those bonds out to their completion. So we'll have this discussion at some point. I think the county administrator is interested in getting that loan off the books, and I want to provide a little bit of perspective as to why we might want to do that.
Just, I know that you want to go through this, but just 2 quick points. First of all, the $1 million that you said, I know that it's not your terminology, but when we talk about the county forgiving $1 million loan, you forgive a loan when it doesn't get paid. This was, again, I know that you're using somebody else's terminology, so it's not personal, but the $1 million that came from the settlement, one way to use it was to put it towards paying the bond that the settlement was for. So the fact that the county decided to take it into the general corporate fund, obviously I wasn't on the county board, it wasn't my choice, but I wouldn't call it forgiving the loan when you take money in and you say, oh, well then, so just terminology-wise, just like you think here that the nursing home paid $900,000, we're not forgiving the $333, I think it was paid. The other point that you already made, but I just wanted to make sure, I think when we built the county nursing home, the intent was pre-cost overruns. The intent was for the county or the residents of the county through taxes to pay for the building, and the nursing home only supposed to basically keep itself going, and therefore it can take the Medicaid, and even then with the $1 million subsidy. So I find it disturbing. I understand that there was only $20 million that came from the bond, and therefore when we needed to get another $4 million, we couldn't get the original intent covered, but I find it disturbing that because there were cost overruns that were not due to the nursing home, because the facilities committee was not the nursing home's facility, it was us, we suddenly decide to put it on the nursing home and say, well, from now on, you will take it. So I think the original intent was for the county to build a facility to take care of the people at the nursing home. The fact that there were cost overruns is unfortunate, but I'm not sure that we should burden the nursing home that is, I don't know, barely surviving, but definitely has cash issues, with payments that are not really supposed to be there to begin with. And I'm also not sure, when you said the nursing home decided to take, I'm not aware of any resolution by the nursing home board. I might be wrong, so I might be ignorant about it, but I'm not aware of a resolution that's the nursing home board saying we will take this on, nor is that the county board said you should take it on. So I might be wrong about that, but I don't, and if there was, as I said, I find it problematic with the original intent of the voters to provide a home for the people.
Yeah, a couple of comments. One, you'll note I didn't say the county board agreed to it. I am not 100% sure what transpired at that point, and someone who was on the county board at that time could probably speak to that. That was the arrangement that was made, and to what extent it was, the way in which that the negotiations led to that, or, how that was agreed to, I'm not 100% sure. I think we're on the same page as far as the concept of loan forgiveness. So the forgiveness is a term that came out of the external audit. I mean, they use the term forgiveness is what happened to that loan. So I think we're acknowledging basically it was, you don't have to pay this you paid this some other way, or for various reasons, this does not have to be paid anymore, is what we're getting at. And I'm sorry, if I could say one more thing, I guess I would say, I think you've done a good job identifying, I'm trying to say this is essentially an anomaly. I mean, we can argue, as it's an issue for the county board, whether or not the nursing home should be on the hook for that debt service. The reason it is in large part out of fiscal necessity. At the time that agreement was worked out, the nursing home owed money to the general corporate fund. The general corporate fund didn't have the money to pay the debt service. I mean, I think it was a sort of a marriage of convenience, whether it should continue, and if we were to not want it to continue, where the general corporate fund would find the $307,000 to pay the debt service. That's totally appropriate for something for this board to talk about. I'm sorry, Al.
That's okay, Chris. Jim.
Well, that's good. Well, I think, too, I think for the viability of the nursing home, I think we just need to move forward. I mean, we want, as the discussion went earlier, to have the nursing home run in a positive way and be financially viable to the community, whether it's the hospitals or the people that will go to the nursing home, so they'll use the nursing home. So we want it to run in a professional way, and I think that's one of the things that as a county board we wanted to do. Plus, we can see from the past what happened when the county board, did maybe do that, but it looks good for the whole community when the county board operates and runs effectively and runs the budgets properly. And I think it just encourages people naturally when that happens. So taking it off the books, I think, is just the appropriate thing to do, not just because, she may want to.
Mr. James.
Well, during all that discussion, of course, I don't know if the attorney bills were deducted out of there, but I imagine they were quite high. But it was all related to that building and the nursing home, and I would assume that's why the bills were stuck over there. But when you say about a budget and doing the right thing, I totally agree. But let's remember, there's a lot of departments that we serve that also come out of that budget, and we got to be mindful not to cut one to help the other.
Well, I'll be very brief. I think we've got to also remember that we sold the public on a $20 million building, not a $24 million building, and so there was probably some reluctance at that point to what to do with that extra $4 million when we just went out and sold them that $20 million would build us a really nice nursing home.
Well, we have to look at the aspect of the contractors. I never see contractors get away with such low bonding, and then we have to turn around and pay for them. Even the material, the manufacturers got away on us. And I never was satisfied with the architect. I think he went fishing most of the time on that project. And I asked the question, and I never could get a reasonable answer. How did these guys get these contracts and wasn't fully had the responsibility of paying the bill? Something go wrong, if you figure out, you probably find about $4 million in the bonds that we had to finish out for the contractors and the repairmen, which they should have been responsible.
Mr. Carter.
Agreed.
All right, any other questions? Go ahead, Chris.
Okay, now I just wanted to take a step back and look at sort of overall revenue. And again, you don't really need to look at the numbers. You can just look at the picture. I'm not going to go into a lot of depth here, but what I wanted to do by putting this up here, and this goes back a couple of years just to show that it's basically been stable, is to point out, we talk about nursing homes being subsidized by the taxpayer, nursing homes, getting this property tax revenue. This includes the property tax for the $20 million bond. So this doesn't look like MPAs. These aren't MPA's financials. This is sort of the total cost of ownership to the Champaign County taxpayer of the nursing home. And I think the thing to look at here is these top two lines. That's all of the taxpayer money that's going into the nursing home. So everything else up there, the vast majority of this is fee-for-service revenue for the healthcare services that the nursing home provides. And it's important for a couple of reasons. One, I think it shows that, you know, the nursing home essentially generates virtually all of its revenue, you know, through its own operations. It also indicates the limit to which taxes could solve a problem if the nursing home starts to see a decline or delays in payments or declines in reimbursement rates. I mean, it's nice that the taxpayers provided the building, and the taxpayers are providing about $1 million a year in operating subsidy, but in the context of a, you know, $16 million a year budget, there's only so much that there's only so far we can go looking at taxes as a solution to this problem. Expense-wise, again, similar. This is not going to look, this is pretty much nothing up here should be a surprise, but again, you know, the debt service up here, you're talking about a total of $1.7 million worth of debt service on both bonds in the context of a, overall budget, you know, close to $18 million. So and this is a comment that be familiar to us from the discussion about the jail facilities is, you know, the building is not the expensive part of a facility. The expensive part is what it costs to keep the facility operating, what it costs to pay the people. And as you can see here, you know, combining wages and benefits, wages about $6.5 million, benefits, you know, close to $2 million, $1.8 million. Contract nursing, which is often discussed as, oh, you know, we could we could, you know, put the nursing home on an even keel if we could just take care of contract nursing. Well, these guys are taking care of contract nursing. That's this little, you know, this little brown line here. So I think I just wanted to put things in perspective. Again, the cost associated with running the nursing home, where the money comes from and where the money goes has very little to do with facilities, has very little to do with property taxes. It has everything to do with controlling the cost of providing services and generating revenue from providing those services.
Yeah, I want to go back to the earlier conversation about depreciation.
I'm going to talk about that in the next slide, I think, if I can.
Okay,
save
I'll
some
wait.
time.
I'll wait.
I guess I look at this differently. Can you go back to the previous slide?
Yep.
When I look at that, I'm looking at 12.
Maybe.
Well, hit the back arrow.
There we go.
This is telling me that roughly 12% of all the income that's coming into that building is financed by a taxpayer. If I go to any private business or enterprise, as it's labeled by your own accounting system, 12% over what I'm currently making is astoundingly high. That'd be fantastic for anybody. It's not a meager small sum. It is a large sum, 12%. So I don't necessarily agree with the premise that overall it's so small. So I just wanted to take note of that. It is not a small figure.
I think it depends on whether you are comparing it to a private nursing home or whether you're comparing it to virtually any of the other services the county provides, which are essentially 100% funded by the taxpayer. So it's, I think it is what it is.
It is a matter of how you look at it, and I completely, we'll agree on that, we'll move forward.
I think to Jeff's point, the idea that this would be nice for any private nursing home to get the tax subsidies, I agree, but would they also take the Medicaid losses with it? So I think we saw before that if you take away that depreciation, we're losing about 1.4 million, give or take. So I'm not arguing with you that it wouldn't be nice, but I think that's the whole intent of a public nursing home. And we absolutely cannot support the Medicaid losses without that subsidy. So would it be nice for anybody to get the subsidy? Absolutely. But is it absolutely necessary when you actually take the Medicaid patient with the losses? I think that's the issue.
The only thing, there's two things about this, is that we talked about tax revenue there. Actually, almost all the lines up there are taxes. The only thing I don't see is private pay.
This is the big orange one.
Yeah, I mean, Medicaid and Medicare are all tax revenue. But she's right that we are, as far as the taxpayers say in this county, supposed to take more Medicaid patients, and that makes it more difficult for us. I shouldn't say more difficult. I think it's something we do that's positive for our community, is serve the community and a part of the community that may find it more difficult to do that. And maybe I should have asked this question when Mr. Gieman was there, but the other slide that we had up there, now if you want to go to the next one, has a non-labor cost of $5.3 million. and wages at $6.6 million. And I just thought those were kind of out of whack. I usually see labor costs much higher than non-labor costs. And when he was discussing it, he discussed it as some of the expenses, whatever the expenses were, at $2 million. I just thought that was kind of odd, and I wondered where we'd get more information about those non-labor costs at the nursing home and why they're so high for a business.
I'm going to actually ask Scott to speak to that. This came out of your annual report to the nursing home board from the January meeting. And I don't know, does this look reasonable to you? It's certainly possible I've got something that's classified. I think these were basically from your top level numbers as far as wages versus non-wage expenditures. But I did a lot of consolidation to get those few number of bars, so it may not be entirely accurate. I mean, keep in mind it is a healthcare facility, so there's a lot of payments to vendors. There's a lot of food. There's a lot of consumables. There's a lot of equipment, subcontracts, and things that are not considered. They're not wages or benefits.
And Scott, isn't it true that a lot of services are provided by staff not employed by the county, which are not included in our personnel costs?
Okay.
Because they're services, therapy services, rehab services, they're done through contracts, so they're personnel services, but they're not in our personnel costs.
Well, maybe I can get you to give me that information separately so I can understand. Because the earlier slide you showed like $2 million in costs, and just so I can understand.
Speak to that.
Deb makes a very good point, because I think therapy services, the physical therapists, OTs, and speech therapists are not employees of the nursing home. It's a contracted service, so that labor would fall, I mean, those costs would fall under non-labor, so, and.
Yeah, so we did, therapy was about 0.9, contract nursing was about 0.6. And then this is basically everything that wasn't in any of the other categories. So, I mean, there's a lot in there.
Purchased,
Yeah.
and supply, medicine.
Food and drugs and equipment and. I mean, it's in the, I'll talk about that in a minute, but it's in the nursing home, it's in their monthly financials. No, I'll talk a little about the financials. Every month in the nursing home board of directors agenda packet, there is a complete set of financials from the nursing home prepared by MPA and by the accounting staff at the nursing home. There's a statement of cash flows. There's an operating statement, which is also known as a profit and loss if you actually make a profit or take a loss. There's a balance sheet. And one thing I was talking to Deb about doing is we should probably take the financial aspects of that report out, accept them and place them on file as part of the finance committee of the whole. Because I don't think I'm not in favor of micromanaging the nursing home, but looking at the overall finances, I think, is something that, from an accountability standpoint, we as county board members should do. It'll give people an opportunity to ask questions of the county board's representatives on the nursing home board if there's anything that's questionable. I don't think MPA doesn't have to have somebody here, but it's something that if we do have questions, we can always go back and follow up on that. So I'll plan on doing that. I just want to make everybody aware, the financials from kept internally by the nursing home, which are the ones you'll see in that monthly packet, are kept on an accrual basis, not on a cash basis. And essentially what that means is that they'll report revenue at the time it's billed, not when they actually get the check, and they'll report an expense when it's actually incurred rather than when they write the check. So in a situation where your receivables, your delays in your receivables and your delays in your payables are about the same, you'll get pretty much the same answer off the accrual numbers as you will off the cash-based numbers. Every other accounting report that the county produces, and most municipalities produce, including those produced by the auditor, are on a cash basis. So if you wonder why the numbers don't quite line up, that's generally why. But within each report, the reports are internally consistent. So if you look at the relative cost of items, of expenses and revenue in the monthly report, I think you get a good idea for, to answer Mr. McGuire's question, what are we spending all that money on? I think that goes a long way to answer that. And talk briefly about depreciation. Sorry, because it was a few more slides than I thought. For whatever reason, the external auditor who produces the comprehensive annual financial report considers the nursing home to be an enterprise. And as such, it has somewhat different accounting rules than a regular county department. Probably the most significant anomaly there is it has to expense the depreciation on the building, even though it doesn't service the building debt, which is kind of strange. I mean, it's essentially, they're not making the payments on the $20 million bond, but every year they have to say, well, the building's another year older. We estimate its service life at whatever it is, 30 years. We're gonna take an expense of $720,000 a year and list it as a cost to the nursing home. Now, it doesn't have an impact on cash because they don't actually have to pay it. But if you look at the nursing home's monthly revenue statement, you'll wonder where this $720,000 expense came from. Well, that's where it came from. It's essentially an accounting trick. I mean, businesses use it to give an accurate assessment of their net worth. You can save on your taxes by taking depreciation on your assets. But within the context of a county department, no other county department does this. We don't take depreciation on the jail. We don't take depreciation on Brookings. We don't take depreciation on the courthouse. So again, it doesn't have any real impact, but it does sort of complicate looking at the numbers and assessing the condition of the finances.
Does the payment of that phantom expense have any bearing on the availability of money to pay for the expense when it's actually incurred?
No, and in fact, that's the last bullet point there. Depreciation has nothing to do with funding capital renewal or replacement. I mean, the nursing home has that $720,000 expense. That doesn't mean that we're building up $720,000 a year in money to replace the nursing home when it finally wears out. The county should probably be doing that on all our buildings, and we're not doing it on any of them.
Right. Point.
Okay, so I guess the real focus of this discussion, and the gentleman from MPA did a good job talking about this, but I'm just going to run through it real quick, and I think it's not too bad if we hear it twice. The real issue is late payment contingencies. I mean, currently the state's paying more or less on time. The nursing home is an expedited facility, thanks to the lobbying efforts of MPA and other nursing homes. We do get paid in a relatively timely fashion. What happens is the state gets paid by the feds, but then the state can slow roll issuing the vouchers to try to make, paper over its own cash shortfalls. So it's reasonable that we look at having contingency plans in place. Some of these items that have been suggested, things that MPA has already talked about, get the governor to agree to tell the relevant state department to pay the state homes first. We could issue revenue anticipation notes. We could try to get line of credit, delay our payables. And then in the long term, it's been suggested we should look at an increase of the tax levy. The first one, executive action, essentially to go back to what MPA has already told us, the governor's office could pick up the phone, tell director of HFS to treat us like a critical access hospital or a safety net hospital, which are institutions that treat a large number of Medicaid patients and have limited cash resources. What do we hear from the governor? Well, they're working on it. We'll see what happens. Revenue anticipation notes, I won't go into much detail because we already heard about this, but basically it's an annual or quarterly note that uses the state receivables as collateral. If the county has to back them from the general fund. If the state pays within the loan term, everybody's happy. If for some reason the state pays past the loan term or defaults, then the county has to pay the outstanding balance. And it's a matter, Ms. Schwartz was getting this, right? What is really the risk that the state's going to go out 15 months? Well, it seems pretty low. So our job as county board is essentially to weigh the risk of various potential delays against where we'd get the money if we did actually have to pay these things off. It's worth noting that the general corporate fund already borrows from internal funds, including public safety sales tax and others during the year because of the seasonality of our revenues, right? We receive almost all our revenues from property taxes, and those bills go out in June and September. So, by May, if we didn't have the ability to move money around within the county, the general corporate fund would be $1 million in the hole, and we wouldn't be able to make payroll. So, we don't exactly have a deep cash reserve in the county which we could use to back these notes. So again, we want to ensure that I think a reasonable course of action, if we decide to go this route, is to say, well, we're going to issue notes that are long enough term that it's, very, very unlikely that the state will not pay within the term of those notes. And if it does happen, then, here's where we would get the money from, which would obviously presumably have to be borrowing from another external source. The county going and turning around to borrow money to pay the bank that issued the notes. It's not a great looking scenario, but it's the type of risk analysis that we get paid to do. Line of credit was touched on as Scott said in response to Ms. Petrie's question. You currently are not allowed to do this by law. Of course, the laws can be changed, and there's been some effort along those lines. It'd be, again, same problem as the revenue anticipation note. You're assuming the state's going to pay someday. Seems like a reasonable assumption, but it takes a little bit of the time pressure off. And again, since it's currently illegal and it would require legislation to make it legal, we don't know what the terms of that legislation would be, so it's still sort of an open question. Delaying payables. Scott talked about that. We've done it before. We can do it again. It's bad because it hurts our vendors and it discourages our vendors from doing business with us. They can charge interest. On the other hand, if we're doing it, chances are probably all their other customers are doing it too because we're in the same sector. And, we could use that approach to accommodate a minor delay, couple of month delay in state payments. And then one other discussion that's been talking about is the nursing home tax levy. It's currently set at a 3% or 3-cent rate. The statute allows us to raise it up to 10 cents, which would approximately triple the revenue to $3 million a year. We can't just do that. We would have to take that to the voters, or an outside group by petition would have to take that to the voters, and of course a majority of the voters would have to support it. So it's not a sure thing by any means in this economy or any economy. If we were to do that, we wouldn't really see any revenue until the following June when the property tax bills come in. So, and again, as I pointed before, Mr. Kibler, it makes a good point, but that in the overall context of the nursing home revenue, you're talking about currently $1 million, potentially up to $3 million in the context of $15 million. So I think that's the kind of solution we could look at if we're concerned about like long-term deterioration of reimbursement levels. I mean, if we were, I think Scott mentioned that there was a possibility of a 2% cut that would have cost us $53,000 a year. I mean, numbers like that, I think that's where it's appropriate to say, look, this business is slightly less profitable than it was before due to market conditions or due to reimbursement rates. It's reasonable to expect the taxpayers to chip in a little more. It's the kind of solution I think you could look at as a solution to that problem, but it's not really a realistic solution to the problem of payment delays because the uncertainty and the time frame.
Good question. Yeah, am I right in that any ballot question like this would be the authority to raise the rate to a certain level, not necessarily the rate that we would raise it to?
That's correct. Yeah, if you went to the voters and said, the language, unfortunately, is very, we ran into this, we've run into this before, the language is very poor, right? It essentially says, shall the county raise the rate to this? What it means is, shall the county have the option of raising the rates to up to that? But apparently they think the voters aren't smart enough to understand that, so the language is confusing. But yeah, if we went out, or if we or somebody went out and got that raised to 10% by referendum, we could adjust it on an occasional basis to have annually. When do you set the levy?
You have 4 years to get the levy to what the voters approved. After that, tax caps kicks in, and wherever it is at the 4th year, that's where it stays under tax caps.
Okay, that answers your question.
Rachel. 2 points. My main concern, and that was the concern when you guys brought the referendum before, was the public perception of how the nursing home is doing. So we talked before about the choice that people have, especially the Medicare people, in coming to a home. If you think that the home, and that's my concern about, as much as I like the financial conservatism and so on, when people start panicking and say, oh, the nursing home is so terrible and they're going to start issuing revenue anticipation notes and, 15-month delay and, and so on, and the panic kicks in way before it's even halfway reasonable it might happen. Do you really want to go to a home like that? Chances are you may not. And so it's not a neutral question to say, oh, well, let's talk about what could be going on when things go wrong. could very well be a self-fulfilling prophecy where you say, things can go wrong. So, I don't really want to be a Medicare patient in a closing nursing home. So that's my concern. The other thing is about the 3 cents to 10 cents. We've had enough people in public participation saying the public safety sales tax was supposed to have a sunset, and then the county board got together, decided not to have a sunset. So why would we think that you're allowing you to bring it to 10 cents, you're not going to bring it to 10 cents, okay? That's a very valid point, whether that's going to happen or not. So between the two of them, but more so the short term, as soon as you start kicking, I'm not saying we should hide problems, by no means, okay? We should definitely air all the problems that are there, but to put excess weight on the problems beyond what you actually have and create an impression that's not there, and by that shortcutting the Medicare stream of cash flows, which will put the nursing home in problem, I think it's not responsible. So that's all. I mean, I want to make sure I'm not trying in any way to hide problems or not talk about them. This is going to be wrong. But to put excessive emphasis on them and by that creating the problem that may not have been there either way, I'm worried about that.
Mr. Alex, last year, I believe we initiated tax anticipation notes for the nursing home, and it's really not discussed much in this particular document. Can you discuss, especially for newer board members, the differences between a tax anticipation note and the revenue anticipation notes? Because they are very different, and one's employed right now and one's not.
Yeah, I'll do my best. Essentially, a tax anticipation warrant is a recognition of the seasonality of the receipt of taxes. So essentially, if you have something like the nursing home or any other county department that receives, whose expenses are essentially consistent throughout the year, but we recognize that we get a big tax payment in June and September. The tax anticipation warrant is essentially something that you issue at the beginning of the year to provide the money that they'll be getting anyway, to borrow. Basically, you're borrowing to give them the money that they'll be getting when the tax revenue comes in the summer. So it's considered essentially a sure bet in that we basically know what the tax levy is going to be. We know approximately what the value of taxed property in the county is. So it's a little different than the revenue anticipation note in that it's backed by property tax, by a known amount of property tax that will be received on a date certain, as opposed to the revenue anticipation notes, which are based on a known amount, but with some uncertainty as far as when it'll be paid.
I'd like to respond to Ms. Schwartz's concerns. I think there's a way of looking at the two issues that you brought up. One is the very positive aspect of bringing this out for the public to understand exactly what is happening with the nursing home, and if indeed we need to go to the public for an increase in the amount, then we've certainly done many steps forward to get that started. The second is everybody has praised the nursing home, and I would like to see the nursing home distinguish itself even more so from other nursing homes within this community so that the census will increase. If in fact people realize that it's an excellent nursing home but is problematic in the way of census numbers, that might just be the tipping point that more and more people want to keep this nursing home and are more willing to put people in this nursing home. We're talking about it because we feel very responsible. It's a county entity. Private nursing homes could be just as precarious. They just don't talk about it. So I don't see any threat to the longevity of that nursing home by having any of these conversations.
Yeah, I believe the point of a study session is for us to get all the ideas and issues and potential situations on the table. And any indication that things shouldn't be brought up because they might be incendiary or might discourage people, I can't go along with that. I think we have to talk about these things. I think study means we might even examine things that are not likely, things that we don't plan to do. just from a standpoint of saying, yes, we've talked about it and we're not going to go there. So I would also disagree that we shouldn't be looking at every stone and turning it over.
Just a couple of things, Chris. On the tax anticipation warrants, the way I understand them is you go out a year ahead to pay the bills that are coming in now. So the following year, if you didn't go out again, you have no operating money coming in off of taxes to spend, so you have to go out and borrow money somewhere else unless you get an influx of a lot of good paying people. And that's my intake on that. But the other thing is when we talk about it, and like Rachel was talking and Patsy, and this is sort of on the same level, but when the Chenute Air Force Base announced it was going to close, it was a government entity which brought in tons of money to that community, tons of money, and supported a lot of things. It happened that we had to look at what can we do to make things better instead of how much more money are we going to throw into something by fighting it and draining our resources. And I'm not saying that's what we're looking at here, but I always get this feeling that because we all say, well, we need to do this, we got to be mindful that we represent, all of us represent a different portion of this county, and some are hurting more so than others. The communities I represent out in that northern part of the county, when I hear a dime here or like the tax we passed for schools, it all sounds good when we're sitting here doing it, but in the long run, the folks that are struggling the most are getting hit harder and harder and harder. And I've seen folks that have lost their whole livelihood. Granted, $5 isn't going to break some people, but it's the accumulation of it all. So what Quisenberry just said, we need to put it all on the table. I mean, we've got to be, no matter what our heart tells us, I mean, I would never, ever want to set my mom and dad out on the street. But if I couldn't afford to keep them, my brother better. You know, that's just the way I look at it. And we got to be sensible about it. So.
I just wanted to wrap up. I guess, I think we've heard, I doubt you've heard anything from me that was much different from what you heard from MPA. I mean, I think we can probably agree, nursing homes in reasonably good shape financially, certainly a lot better than it was in the past. Its cash balance is slowly increasing, and it has enough of a cash reserve to weather, short-term issues. That's assuming that we continue to see reimbursement rates and payment timing comparable to what we're seeing now. The obvious risks are that that's not true, that reimbursement cuts happen or that delays in state payments happen. Obviously, the delays in payments are much more, I think, a significant risk. I mean, reimbursement cuts, if they happen, will happen slowly and are the kind of thing that we can decide as a matter of policy, how we're going to address. The state just waking up one day and saying, I don't feel like paying my bills today. We are in a state that tends to do that. I agree it's quite unlikely that the state's going to be more than 6 months out or 9 months out. On the other hand, in Illinois, as in dreams, anything can happen. Our last two governors are in prison, which tells us something. I think probably pursuing an approach where we, hope for the best and still provide some type of borrowing capability to be able to accommodate foreseeable delays in state payment would be prudent. I think we need to consider those kind of contingency plans, and again, just stay ahead of the situation. I think you saw early on in the presentation the grants that were made from the general fund to the nursing home fund. I mean, the nursing home was put in that situation, I think, because there was evidence of problems accumulating, but nobody really paid attention. And I think this past board and this board is doing a much better job at staying on top of the situation. We've got MPA in there every day. They're reporting to us on a periodic basis, and we're looking at it too. So I think, we talk about doom and gloom. I don't see a whole lot of doom and gloom here. There's this, I heard earlier today, there's going to be a study session on the financially troubled Champaign County nursing home, and I guess I would contest the description as financially troubled. I mean, it is. I don't think it's financially troubled, but it is at risk, and it's at risk of the state failing to fulfill their obligations, and that's just something we have to be prepared to deal with.
Chris, is that it on your presentation?
That's all
Thank
I
you very
got.
much. All right, it's 2.5 hours, and I wanted to take a 10-minute break, actually. I don't know about you guys, but I need a break. So let's take a 10-minute break, 20 of, 19 of, and we'll get back to Mr. Quisenberry and Mr. Maxwell. Thank you. take a break. Okay, let's take our seats, please. Okay, where's Mr., no, well, I'm back in session, but Mr. Quisenberry isn't here. So, well, James, where are you? James was standing by the back door. He didn't want to let anybody out because he wanted to make his speech in front of everybody. And now he's out there and, well, yeah, but they have a thing going. Quiz wanted to get it going and then turn it over to, he had a, would somebody stick their head out the door and scream for Mr. Quisenberry, please? Is he coming? All right, he's coming. There you are. Okay. Okay, order. All right, Mr. Quisenberry, you're up.
Yeah, I'm gonna have some things to say the next time our concession contract is up. Is fighting with the soda machine. Okay, so I'm gonna be pretty brief. I'm sure you're all glad about that. What I'd like you to do in your booklet here, I want you to turn to the page which is, getting there, 31 of 66. And what I'm gonna talk real briefly, and then I'm gonna hand it over to Gary. I'm just gonna go back a little bit. Now, I'm talking about this as the policy chair, but you should all know, and if you don't know, you're gonna know now, that the Nursing Home Board of Directors was actually created out of the Justice Committee, because nursing home previously was governed by the Justice Committee. And by an order in January of 2008, by a 2/3 vote of the board, the Nursing Home Board of Directors was created with the intent of, and this is my interpretation of it, with the intent of providing some expertise to help govern the nursing home in areas that you don't necessarily get. You might get county board members who are versed in these areas of expertise, but you're not guaranteed to, because we're elected by the people and we don't have a set criteria of qualifications to get elected. So what I'm going to talk about briefly is, so in 1990, or in 2008, the Nursing Home Board of Directors was created, but on this sheet on page 31, which I believe Deb assembled, right, Deb? Which is kind of an overview of what the bylaws say that the Nursing Home Board of Directors are expected to do. I'm going to talk a little bit about what the county board is still expected to do. And item 1, I think, is the important thing here on that first page. The authority and ultimate responsibility of the operation of the home shall rest with the Champaign County Board. There's been some concern about abdicating our responsibility to the Champaign County Nursing Home Board of Directors. We have not done that. We are still the ultimately responsible. We may have not felt completely informed or close enough to what's going on, or felt like the two-way communication was not sufficient, but we still own it. The buck still stops with us with regard to that responsibility. The other thing I wanted to point out was on the second page, page 32 of 66, is these items that are solely within the responsibility of the county board, not the Nursing Home Board of Directors. These items down here, 1 through 5, and I won't read them to you, but I mean, these are significant responsibilities that only we hold. And the rest of this goes more into detail about what's expected of the Nursing Home Board of Directors. And at this point, I'm going to hand over the floor to Gary to talk a little more detail of that and the operations of the home.
Rach?
Stay at his seat.
What's that?
Tell Gary just can stay at his seat. He doesn't have,
He's already-
that mic isn't working that well.
Oh, the mic's that working
mic
well,
isn't
Gary. Would
working.
you just do it at your seat, please? Rachel, you had a comment?
I just had a quick comment in terms of the timeline, because you mentioned it was January 2008. So just to put it in perspective, this was before MPA was hired. So I think at the time when the county board felt that there is expertise needed is because there was no professional management company. And so I don't know what we feel about it now, but just to put it in perspective, when the nursing home board was formed, there was no professional management company, whereas in June 2008, MPA was hired and started, as Scott said, to operate in July.
Yeah, I neglected to point out that it was just July of that 2008 where MPA was brought on board. I didn't research this in enough detail to realize whether that was pushed more by the Nursing Home Board of Directors or the county board, but. Oh, about the same time? Okay.
Wait a minute. Chris, go ahead.
So that's an interesting question. Was the nursing home board constituted at the time the MPA contract went into effect?
Yes.
And did the nursing home board weigh in on the MPA contract? I mean, were they basically created to evaluate the RFPs? That was one of the, so the nursing home board was in on it
Yeah.
essentially from the beginning. Okay, thank you.
Swell.
Thank you. As part of my preparation, I took a look at 3 of the operational documents that make up the Nursing Home Board of Directors. Mr. Quisenberry is absolutely correct. We cannot delegate the responsibility for the home. We have designated a certain amount of, and delegated a certain amount of authority to the Nursing Home Board of Directors. Essentially, the Board of Directors is given the authority to manage the home through the nursing home administrator. One of the things I discovered in these documents, they don't mesh very well together, and I think that at some point in time, a group may want to sit down and realign these documents so they all kind of fit together. For instance, we're supposed to govern the home through the Board of Directors, and then they oversee the operation by directing the operation of the administrator. Well, the administrator now is the employee of MPA, so we may wish to change the wording in some of that in the documents. The Nursing Home Board of Directors basically has 4 primary functions. That's providing of high-quality service. And incidentally, the policy book does require that we get, the Board of Directors get quarterly quality improvement reports. I'm not sure that's been happening because, and that is in the policy book. The bylaws need some tweaking. You all can do the reading. Again, nothing terribly serious in there, but do require a little bit of realignment. MPA's contract, for instance, in 2011, we renewed the contract for another 3-year period. It was in 2 parts. One was for the management, and the other was for the business management. And I've since requested some information, and apparently we inserted that contract portion into the contract because we and MPA were having some real difficulties with the reporting of the financials. And so at that point in time, the county, I believe, did away with the position of business manager, and then we employed MPA to do that for us. Some of the issues I'm not quite sure of. We allow the administrator to enter into certain contracts, and I'm not sure now with the fact that they're now, the administrator now is an employee of MPA, if that's still appropriate. Again, that's just another issue within those documents that we may want to look at and try to realign.
Grief. Unfortunately, I was there at the time. It was when the contractor took over, the director had been under fire in the board. There were people that were for him, there were people that were, anyway, he was a controversial figure. It was stated that the new director would be approved by the board. That was not done. The contractor did it de novo without consultation, and it was an accomplished fact, and it was never challenged.
I'd like to add to that. I was also here and the vice chair. Microphone, please. Oh, I'm sorry. I was the vice chair of the committee at that time, and that's what I stated earlier. A lot of this went on and bypassed the Justice Committee. And that's what I was alluding to. When we started playing politics, we don't do ourselves any good and the people that we supposed to be representing. And it got really bad. And at that time, I'm gonna just tell you that the Justice and Service Committee just lost all focus of what's going on within that department. It just left. They started bypassing us. And when we know anything, they coming up with issues and ordinance and passing. And we didn't even, most of the Justice Committee didn't know anything about it or had authority to do anything about it. And that's what I mentioned to the contractors. Low bonding. I don't know how some of them got the contract with the bond they had.
I need more.
Okay, we sitting up here looking at pictures up here where mud on the material was going in the building. Wet material going in the building. That's why you got the funders from in that building. Even the heating system wasn't adequate because nobody checked the manufacturers. You see what I mean? It didn't even, the standards wasn't even up to the measure that was going in the building. But as a representative of that committee, we would just bypass and it got all out of hand. And then later on, we end up with the committee as a whole. And that was really, to me, was a dictatorship. And you never got nothing done. So that's what happened.
Yeah, I need to add something. The resentment that I felt at the time came through my statement at this time, but I must say that that contractor has not been what you call a fatal mistake. I mean, he's, in my viewpoint, from that perspective, things have worked out pretty well.
Thank you. To respond to the first part of Ralph's comments, our contract with MPA does state that they will employ an administrator. And it also that the administrator's salary will be pre-approved by the board of directors or governing body of the nursing home, which is the nursing home board of directors. And that was done. And MPA did comply with the contract. Some of the other provisions that the board of directors are supposed to be involved in planning, managing, and maintaining the financial viability of the nursing home. Again, the way you have it set up now in the policy book and the bylaws, is the county board retains responsibility and ultimate authority, but they have delegated a certain amount of authority to the governing board to manage the day-to-day operations of the home, acting through, according to these, the administrator. Again, we'll probably want to change that to say MPA. I think without getting any further into the details of the contract, which I think from time to time would be good for all of you to read with MPA, I will say a little bit about the nursing home structure, which is basically the flow chart. Essentially, what the county board did when it went to a nursing home board of directors and an MPA contract, they inserted 2 more layers of management between themselves and the main operations of the nursing home. I'm talking about the RNs, the administrator, and that sort of thing. And the other folks, even the CA, down to the CNA level. Whenever you insert more layers of management, you run the risk of diminishing the back and forth communications within the organization. And I think this is one of the things that has concerned us as a board as a whole. And I feel like we can improve on that. I hope that the new nursing home board of directors working with the county board will improve on it, and we would be looking for any ideas. I think Chris has a very good idea in that the financial be inserted into the monthly county board report on finances. I think that will go a long ways to helping out.
I have a few reflections because that's when I actually originally started with this board. And from my recollection, the county nursing home was hemorrhaging, and it was hemorrhaging very quickly. And things needed to be put in place very rapidly and very quickly. I think that the community, and I think even the board members, questioned their ability as board members to operate a nursing home. I don't think that anybody around the table, all 27 of us, knew anything of how to run a nursing home. So I think there was an outreach effort to try to get expertise to be able to advise the county board members and inform them of how to run a nursing home. But I think there were also other deficiencies, and those deficiencies came in the high pressure of the job of directing a nursing home. And I think a lot of people did not have faith in the director of the nursing home. But we, meaning the county board, hires the director of the nursing home to do its job. I think the problem is like Mr. Carter has indicated, we don't no longer hire or fire or evaluate that county board employee because we at one time had left it to the advisory board. The advisory board does not have or did not have the power to do that, but they did. So as we moved forward, I think MPA did an excellent job to get us out of the hole and to put us, almost in the black like we are today. So we are very grateful in that. But at the same time, it's an entity that it was only supposed to last 3 years. And after 3 years, they were supposed to train and educate the county, county nursing home director so that that person could do the job of MPA. So we have MPA, and we have an inefficient director that's not doing what he or she was supposed to do. So, but my impression was that we were hiring MPA to train the administrator so that MPA will go away after 3 years. And after 3 years, we managed to keep MPA because we were still hemorrhaging. So we decided to keep MPA so that we could continue to get out of the black. So therefore, our administrator, I believe, resigned. We had nobody. The advisory board was already in place, so the responsibility was left up to the advisory board. They hired the director, and then I believe that responsibility and communication didn't actually come back to the board because we felt that we were bumbling idiots. We didn't know anything about nursing homes. That's at least the way I felt, the way it was portrayed to us. You board members don't know anything. We need professional people in here. We need people with a background, information in nursing home directorship. So now the problem that I at least foresee is that there is no control over the administrator of the nursing home, because I don't even think that the advisory committee controls that. I haven't seen any evaluation on that director, because it's MP3 that is responsible of hiring that administrator. So all along, I think that it's true what Lloyd Carter has said, that we have very little to do with the administrative part of the nursing home, other than when we get some of the nurses or employees complaining about cutbacks or complaining about some of the low salary increases and so on and so forth. That has been my recollection. I knew that we renewed the contract in 2011, and I think MPA has done a great job, but I think it's time for us to start backpedaling and take control of our nursing home as a county board and hire an administrator that would do the job that MPA is doing.
I just want to correct some of your statement. I've been here almost all my life, and I knew we had a nursing home when I was a kid. The old nursing home. And I got on the board, I never heard of a dysfunction of that nursing home. Am I correct there? Well, you wasn't the first one, but I think Miss White was the, yeah. Up until you came aboard, you find any problem with the operation of the nursing home?
The operation of the nursing home began to struggle about 2002.
Well,
And it struggled from 2002
Right.
until 2008, when MPA was brought on board.
That's what I'm alluding to. That's what I'm alluding to. That came on. In fact, the matter, we fired one of the directors before you came, when you just got here, didn't we? Okay, so we knew right off that we wasn't making. Now, after that, that's when we got a gentleman that stayed there. I couldn't understand it, why they did it. And I'm saying, well, if that was me messing up $1 million, I'd be gone. But they let it sit right here and run the thing in the ground. Now, that's the fact about it.
Thank you, Mr. Chair. So just a brief, hopefully very brief statement. There were a lot of things that were happening around the 2002 mark through 2008 outside of this nursing home. First and foremost, in the day, every county in this state, I believe, had a nursing home, because Medicare would just throw you money. It was a money parade in many respects as compared to today. They've really clamped down, which is why you see the vast majority of the county nursing homes no longer in business, because they realized that the cash cow was no longer there. So while, yes, there were a lot of things happening internally, there were a lot of external factors that were contributing to why we're getting into a predicament, which is why we're here today. So keep that in mind, too, that you had external factors. The second thing I'll note is that I totally agree that this 22-member body should not be doing day-to-day or even, I would even say at the board level, oversight of a nursing home. Quite frankly, they're entities that are very complex. They have a lot of moving parts. We spent 4 hours here today, and I don't think any of us knows more than 1% of what really goes on in the nursing home. So to try to dictate in terms of a microcosm is not what I think this board needs to do. I think we have to keep the nursing home board. That said, I completely agree. We have to expand a little bit in terms of our knowledge. I think we went from really microcosm to then exploding out a little bit. Now we need to find that happy median. So doing things like adding more county board members to the nursing home board may be something to look at, because inevitably it's a communication issue. Right now, everything we've heard today is all about the past. It's all about how we got here. We talked a little bit about gloom and doom. What we've not talked about, and what I really want to hear, and this goes back to the provision of high-quality service. you know, we talked about today how, you know, a lot of people love and attest to our nursing home, and I'm one of them. I think that we're doing a good job. But there's a lot of room for improvement. When you go to the Medicare nursing sites, we don't get 5 stars in everything. In fact, we don't get 4 or 3 stars in everything. We're getting dinged for many different things, but we don't know that. And what I want to do is have a very systematic way that this board can understand how everything is truly working at the nursing home through better communication, whether that's, it includes mechanisms to improve our overall Medicare ratings, as well as what we're doing to look to the future. What are we going to do to increase Medicare dollars? As I mentioned when I started this diatribe, Medicare is really clamping down. So what are we doing? What are the steps that we're doing in full-fledged detail, going to the county board and nursing home board, to really understand our marketing strategy, to really understand what we're going to be doing to capture those legitimate Medicare dollars, and then bring that back to the county board every quarter or every 6 months to talk about, here were our goals, here's where we are, here's where we're going to go. And that's where I really want to, and I think at that point, if this board understands, okay, we're currently at 2 stars, we want to get up to 4 by this time next year, and as we get more surveys and audits in the nursing home, we go up. I want measurable insights that can be communicated to this board so that this board fully understands the true health of this nursing home. And I think really that will alleviate the vast majority of the concerns of this group.
Before I make my comments, I do want to assure everyone I'm very supportive of the nursing home. And the spirit of my comments are to figure out how we can accomplish this. I agree with Mr. Kibler. I have said some of those things publicly previously. It is a communication issue. I do attend the nursing home board of directors meetings on a fairly regular basis, and when I do not personally attend, I read the materials. My observation is that the board of directors does not do the due diligence job that we have laid out for them to do in the bylaws. I find that very disappointing because the purpose, and we've been reminded of this many times by previous county board members, that we set up this board of directors, we should listen to this board of directors, and we should follow what they say. In theory, that's fabulous. In implementation, it isn't working. So I would capture some of what my colleague just suggested. I'd like to see the communications increase. I am not for micromanaging that nursing home. I am very much for expanding the board to 9 and the 2 additional members be county board members, 1 from each caucus. I have added up the costs, the annual cost to administrate this nursing home with our contracts, a salary for an administrator that we had no say-so in, and it was only the board of directors that we relinquished that to MPA totally. And it's costing us taxpayer money as a county over $400,000 a year. That's the cost for administrating this nursing home. It includes paying the board of directors, MPA, the compliance contract, the administrator's salary. Well, I figure that at that amount of money, we could hire 3 administrators and they could do the job, or we could hire 2 and save some money in the, for the tight budget that we are presently discussing tonight. So these are some of the things that I do hope along the line that we discuss that. We discuss whether we need an outside consultant or we need staff to run the nursing home. It's clear that the county board should not be doing this. How do we improve our communications between ourselves and the board of directors? And I do hope that we can set up a committee of 3 county board members that do focus on some of the issues Mr. Maxwell brought up, and that the nursing home documents can be written so that they are aligned and that things are very clear as to how things should function between the nursing home, the board of directors, and the county board. Thank you very much.
That's all right. I always forget it. There are some models we can look to. We hold ultimate responsibility for the sanitary district and also for the MTD. We appoint the director of MTD. We appoint members of the board. We're responsible. The means by which we exercise that responsibility might be applicable to managing the county nursing home. But the objection that I expressed, which is reiterated by a number of people who are veterans of the day, was that as that director was appointed without vetting by this board. Now, that vetting might have been a pure formality, but it's pretty much essential.
A couple of things. For one thing, I don't see how we're going to get these umpty dozen stars for Medicare when we have to use the Medicare to subsidize our Medicaid patients. You know, nursing homes that just take the Medicare and private pay patients and raise the private pay costs can get lots of stars out of $458 a day. But we are subsidizing Medicaid patients, and we have a policy of taking as many as we can. So I think that's a problem. And as far as MPA goes, I think we're getting a lot for our money. I think, you know, they pulled us out of the ditch, and I think they've done a fine job.
Jeff?
I'll just clarify one quick question. When I mentioned Medicare stars, so it's irregardless of how many beds are actually used by how many Medicare days are used, it's more of a quality rating. So for example, how many times did someone fall and break their hip? Was somebody in immediate jeopardy at the time? It's really no measure of how much Medicare is used or not used. It's more of a quality score for how the treatment or the quality of care is at the nursing home. So it's really irrespective of level of usage of Medicare or Medicaid beds per se. So it's not really a measure as I think you were interpreting it.
Yeah, then I'm gonna hurt. But since I've been here for started my 21st year, and had the opportunity, and I want to relate back to what Patsy said. Patsy, a board member, is have the opportunity. That's what NACO is for. That man up there on the wall, the first one I went to, wasn't politics. He was a Democrat and I'm a Republican. But he taking me around to every meeting. I mean, we got up early in the morning. Sometimes I didn't feel like getting up that early, but I got up and followed him. Now, NACO keep you abreast on every new entity is coming up. Medicare, if you go there and don't go out in the streets, if you serious about serving your county, they teach you everything you want to know to run this county. Only thing that we don't get here is the participation. And that's the shortfall. But if you go to NACO, roads, health care, they have a seminar for every one of those programs. And it's your responsibility to take notes and bring it back to your county board. So it's nothing that you can't learn if you put the effort to it. And that's the reason I have to make these statements, because it seems like some of y'all haven't had the opportunity to learn all of these entities that we have available for us. And nothing left out. Every entity we have in the county, they have it right at those meetings if you attend them. Now, to take the notes and bring them back, that's up to you.
I don't want to put words in Ms. Bergson's mouth, but I think the point there with regard to the Medicare stars is that we have as a result of the substantial portion of Medicaid patients that we treat, we have financial challenges that sort of gold-plated nursing home that only takes private pay and Medicare patients might not have. So, I mean, I'm by no means implying that we should not challenge ourselves to provide the best quality of care that we can. But I tend to wonder, I mean, we see these ratings for colleges too, and if you really dig into the ratings, a lot of times it falls not to, how good an education you get, but, how many swimming pools they have and how many research facilities they have and so forth. So I'm wondering, I guess, to the extent to which it's realistic for a home like Champaign County to compete in that arena, not because the quality of care at the home isn't good, but because the rating system would tend to favor those who had the financial resources that a private home that didn't take Medicaid patients might.
I kind of want to ditto what Lloyd just said about the communications issue. These meetings are posted every month, and I went to the last one as my first meeting on the Nursing Home Board of Directors, and Patsy was the only member of this body there that wasn't on the board. It's open for people to come participate, to speak, to educate yourself about what's going on. I mean, you can't put it all, there's a point at which you have to educate yourself on the issues, and you can't put it all on the nursing home. Now, that being said, I'm more than happy to do my part as a member of the Board of Directors to communicate better to this body and to regularly report after my meetings on what's going on, and let me know what you want to know. My second point that I want to make is something that I don't think it's even really been mentioned tonight, is one of the other handicaps that we have as a public facility is that we have a negotiated labor contract with employees who are all in the municipal retirees fund. And from my understanding, in many, many nursing homes, they're lucky to even get 401ks. So we are taking better care of our employees, which leads to potentially better care, more retention, and things like that, which are all I'm for. But people need to be aware that that's also a handicap that we're dealing with that other nursing homes don't necessarily deal with.
First of all, I'd love to see a swimming pool at our CCNH. I think it'd be fantastic. Our ratings would go through the roof. But we can divulge into that at some other point. But long story short, everybody's kind of judged upon that. In fact, your ability to be paid by Medicare is judged upon what happens during your surveys. But nonetheless, completely agree with your statement that employee satisfaction and employee morale is absolutely critical to seeing the best patients. That's another score that's generated by Medicare's overall staffing rankings and whatnot. And we do well at that, and which is I'm pleased to see. So I'd like to see more in communications in terms of what we're doing to retain. We talked about retaining top talent, but what are we doing? What are some ideas that this board could generate to help retain that top talent? I think you brought up a very good point, and kudos for that.
Yeah, I like the idea of Josh bringing us information from the board on a monthly basis. I think it would be very helpful to all of us for that kind of communication. Thanks, Josh, on that. Was Mr. Quisenberry next? Go. Oh, I'm sorry, Mr. Maxwell.
That's right.
I'll be happy to work with Josh and bring reports to you. It seems to me that, to conclude my remarks for the night, and probably to say something that we don't really want to think about or recognize, but we've got 3 policy decisions to be made. Some on the short term, and others can be delayed a little while. I think we have to, on the short term, make a policy decision on RAN, whether or not we're going to do that. It may be something that we have to do on a fairly quick notice. So that's a policy decision the board needs to make. Another policy decision, which is probably not quite as pressing, but is something we should make, is whether or not the nursing home is going to be continued to be expected to pay the $4 million, the debt service on the $4 million bond. Again, if they are, that'll be the way of it. If not, then we'll have to make some other adjustments within the county corporate fund. But that should be a county board decision. It should be. And the last one is probably the most difficult from what I've heard tonight. But eventually, you will have to face it. We as a group will have to face it. What percentage of Medicaid population do you want to have at the nursing home? You'll eventually have to make that decision. If it's 100%, it could happen over time. Then there'll have to be other means of funding the nursing home. But this county board eventually will have to make that policy decision as well. It's not something that we ought to force upon MPA or whoever is our contractor at the time. It's something we've got to decide. What I'm hearing tonight, y'all want to keep the doors open to Medicaid. If so, we're going to have to figure out a way of funding it. Thank you.
Yeah, I have a couple things that I've heard said that I feel like I have to make a comment on. First of all, I know we appoint the MTD directors, but I don't believe we approve the executive director that they hire. I think that's true with the sanitary district too. We make the appointments, but they hire the employee that runs the operation for them. That's a model that is throughout situations. I believe that if we hire MPA to run our nursing home for us, that's their job to do that. They should hire the person that's going to run that for them, and he should be answerable to them, just like they're answerable to us when we renew their contract or review their contract on a regular basis. So I would hesitate strongly, and in fact, I'd probably be against any situation where this board becomes more involved with hiring the nursing home director unless we went back to that old model where that director reported directly to us. Because that's not how you delegate. That's not how you create bodies to manage situations like we've done with the Nursing Home Board of Directors and like we've done to bring MPA in, because we clearly could not do it. The other thing I think I'd have to challenge, Patsy, is that $400,000 could hire three directors to run the nursing home for us. Several times tonight, you've said, MPA, go to the legislature and influence things. That's a lobbyist. That costs money. They've taken the operation, the accounting operation, basically a CPA to keep track of the money that's spent there. That's a full-time person. Then you have a director. Then you have the national winds blowing that they listen to and that they distill for us and make it pertinent to Illinois and to Champaign County. I got to say, I don't think 400,000 on what, you said $15 million budget of administrative overhead, that's about 2.5%. If I could give my money to nonprofits that said they had a 2.5% overhead for administration, I'd be signing up all day. So I have to challenge that statement, and I think it contradicts some of the things that you were advocating earlier, like lobbying and other things that are going on. That's not to say that we shouldn't be challenging MPA and looking at what they're doing very closely. It's just saying that I think that value is well spent, and it's not simply a $400,000 director of the nursing home. It's a team that we're acquiring with that. It's a lobbying arm. It's a research arm. It's a bunch of things, and $400,000 would not go a long way trying to put that together on our own. So.
So, and then I would have to concur with what Gary Maxwell says. We have to change our policies and our guidelines, because the way the reporting line stems is that the director of the nursing home reports to the committee, and the committee reports to us. And I think that communication has been lost in transition somewhere. And now no longer does that director report directly to the advisory committee, which reports to us. So we're sort of left out of the loop, and we're like in limbo over here, not really knowing. We get reports, but not very accurately, and we don't get to ask questions of the director on a regular basis when we have our regular board meetings. We don't see them sitting in the audience. As a matter of fact, I just realized that the director is here tonight, and many of you probably don't know that the director is here tonight because you don't know who it is. Thank you.
It on? There is a distinction between the nursing home and the MTD and the sanitary district. We hired a private company to operate the nursing home, a company that operates a number of nursing homes. And as a result, maybe we need a little more control over what goes on. And at the time it was done, it was agreed that they would hire a director and we would approve that director. That was never done. They just hired the director. In fact, they hired the director that was incumbent, with whom there was a good deal of dissatisfaction on the board. Now, I'm just offering these things up. There's tax money in that nursing home. We're responsible for it. If as long as there's tax money in it, we are ultimately responsible for it.
Yeah, I just would kind of complete this and say, I think if we have a board that's responsible for the nursing home, if they want to rewrite their policies, let them rewrite their policies. Like Jeff was talking about, make the nursing home more accountable to that board. We can't manage everything that happens in the county, and have it make its reports to us, as we've discussed. Can I call the question?
Good idea.
Do we have any further comment? Gary, are you complete your, okay. And Chris, I want to thank you guys. I want to thank the MPA. I want to thank Josh and Jeff and all the board members here for a very freewheeling and very, very educational evening. Jeff wants to make a further comment.
Actually, I would like to hear from our director. I would like to hear from the folks that have
That's
sat
a
in the
good
back
idea.
so patiently and hear their
Is our
perspective.
director here? Would the director please step forward?
She's our administrator.
What's that? Administrator. I'm sorry, the term is our administrator.
And is the DON here as well?
Actually, I think that's a great idea, since
interesting.
I didn't know who she was either. And has anyone else here been introduced to this administration? Thank you, Mr. Rosales. I think it was a good point that you made. If you would click the button in the middle, please introduce yourself.
My name is Karen Nofke. I am the administrator. I was previously the director of nurses at the nursing home. I've been there 4 years. I know a few people around the table. I know Mr. Carter. I think right now, when I came in 2009, management and labor, things were going on continually, and I don't see that today. I think people are working as a team. I think we have common goals for quality. It's interesting that you talk about 5-star because our consumers are looking at that information, and you guys really need to know that is a complicated system, need to know what goes into that, and I know that's something I'm going to be talking about next month at the Nursing Home Board meeting. So I think it's important that you do understand that, because even the people who work in healthcare don't quite understand. It's a difficult thing with staffing and your survey results. Our quality measures have changed. They went black for a while with the new methodologies with our rugs, and now they're back out, and there are new measures that we're being measured against. So staff have to start looking at things differently as well, things we haven't paid attention to in the past.
Thank you. There was one thing I think we had mentioned tonight, actually. When I first came on the board, there was a multitude of complaints from the staff. We had, I couldn't remember having the staff come to us and just scream at us on public participation, how terrible the nursing, how they were being treated, how badly they were, how many complaints they had. I mean, it literally were dozens and dozens, and I haven't heard recently any public participation coming in and complaining about the morale or complaining about the problems at I think MPA and the staff over there have now been able to realign many of their policies to alleviate those complaints. And I think that's one of a major asset to us. in the morale of our nursing homes. So I haven't heard anything about that. Jeff had a question first, and then I'll go to Chris. Jeff,
Actually,
go ahead.
just more of a statement and more of an ask. I had a chance to tour the nursing home a few times under your predecessor. I would highly encourage anybody that hasn't had a chance to, I'm going to say that you're going to be the greatest tour guide ever, but really show what the nursing home does and then talk about, okay, we tried the child daycare, but now that room is being remodeled to try to bring Medicare beds for blah, but really emphasize what is happening and how the dynamics of a nursing home work. So if you hadn't had a chance to go over there, really go and do it.
I just wanted to make a comment. I mean, we followed up. Josh had mentioned earlier that one of the challenges of the nursing home is that we do have a unionized labor force, and that we pay, substantially better benefits than a lot of private nursing homes do. And I think that's actually something to be proud of, and I'm hoping that that's something that we can translate into employee morale and employee retention and work toward quality of care. Along those lines, I think it's something. I think Alan made a great point. The relations between labor and management there definitely seem to be better than they have at times in the past. And the union has actually been one of the significant factors, I think, in helping get the agency nursing costs down and things like that. I mean, I think I would hope that MPA would agree with this. We've gotten some cooperation from the union and efforts to, because it's something that we should be on the same side on, right? The union wants their folks doing the work. We want our folks doing the work. And I think that's an area in which the union's been real good at working with us, and I think everybody over there's pitched in, and I think we need to thank them as well.
Thank you, Mr. Chair. I'd like to mention that earlier this evening, Pete Chakowski and Catherine Emanuel from the Nursing Home Board of Directors were here, and I'd like to introduce, I believe she's still here, one of the new seated directors of the nursing home, and that is Mary Hodson. She's here, and maybe stand up or at least wave your hand.
Wave,
so we
Mary,
can,
wave.
So,
okay.
So again, thank you for attending,
We're not going
Mary.
to put you in the hot seat, I promise. Are we complete tonight? Well, Mr. Harper.
I'll speak here a little bit. No, basically all I have to say is, being new here, I really appreciate all the input, starting with Josh to Jeff to James and Alex, Gary, Lloyd. A lot of great comments, a lot across the board, reaching out to each other. I appreciate that. Rachel, or her comments, I don't know if she saw me cringe one time, though. She mentioned property tax to an old farmer, so.
I want to thank all of you. This was a very educational evening I think for all of us. And hopefully in the future, if we have serious concerns about issues, we have it on our schedule. Every month there is an opportunity for a study session. I hope we're not going to do one every month. But I know that we will probably have opportunities down the road. So I want to thank all of you for coming this evening and spending 3.5 hours on learning about our nursing home. And I'm calling for, Mr. J, before we call for adjournment.
Just on a lighter note, somebody mentioned swimming pools a while ago. I can't pass up the opportunity. We had a swimming pool at a nursing home. We built a nursing home in it, and that caused us a lot of headaches.
Call for adjournment, please. May I have a motion? Motion by Mr. Keebler, second by Ms. Astrid. All in favor?